Okay, I think we'll start it off. Okay, so before I start, I'll just tell you how we're going to go about it. I'll go and everyone should keep their mics muted so there's no interference. When I mention the examinee's name, then you can unmute your mic and answer. Okay, if you're unsure about something, then I'll move on to the next name. Okay, so that's how we're going to do it. And if two candidates are unsure, then I'll say the answer. So that because we have a lot to discuss, right? So I want to finish off all the things that we need to discuss today. So just to get things moving along, that's how we'll proceed. Okay. So if two candidates cannot answer, then I'll say the answer. Now, one more thing here is that I have tried to incorporate all the important points that they ask you. Of course, you're going to get some bouncers that you won't see today. That is to be expected. The point is, you should know these core basics. If you answer these basic things that that we're going to discuss today, you will get through the ward rounds and grand viva. Um, these are things you should focus on. On top of this, they might ask you other things as well. That's to be expected in a super specialty exam. But if you can figure out these points that we discussed today and retain those points, then I think you'll be able to get through the exam. Okay. Um, so I think without any further ado, we'll just kick things off. Right. So we'll start off with the ward rounds. This is divided into ward rounds and the grand viva. Now, many things that are there in the grand viva can also be asked in the ward rounds. For example, if someone with a PTBD stent comes, the patient can be kept, for your ward rounds session. So we'll discuss those things in either one of these subheadings. So don't worry, there can be some mix and match. Depends on whether the patient is available or not, right? Whether they'll keep it for the ward rounds or the grand viva. So all that aside, we will discuss it in some area or the other, all the different important points. So we'll start off with the ward rounds. First question goes to Dr. Vaishag. A case of CA breast, was on neoadjuvant chemotherapy, and then during chemotherapy, after 4 hours of receiving chemotherapy, the patient presents with the following findings. Um, Dr. Vaishag, please tell me what the diagnosis is here.
Yes, sir. Looks like an adrenaline extravasation. Um, and the patient is currently with ulceration and grade 4 extravasation.
Yeah. So definitely, breast cancer, most commonly adriamycin is notorious, one of the strongest vesicants, right? So what is a vesicant?
The vesicant can be divided into DNA binding and DNA not binding. It's something that has an ability to cause tissue injury and damage directly by causing.
Yeah, so tissue necrosis or
Yeah.
formation of blisters. Okay, those 2 points. So can you tell me what the DNA binding vesicants are?
DNA binding vesicants are which are anthracyclines, like adrenaline and doxorubicin, doxorubicin. DNA non-binding vincancanodes, vincristine, vinblastine, vinorelbine, and the taxanes.
Yeah, so you're right. So that's how you classify, your vesicants, right? Um, Now tell me, in a case of, doxorubicin extravasation, how will you handle the case?
Yes, sir. Initially, once the nursing assistant or whoever has reported extravasant to us, stop the infusion right away. Then keep the IV line in situ. Try to identify the drug which is extravasated. Now try to aspirate the maximum amount of drug that can be done with the IV cannula in situ. Post aspiration, up to 5 to 10 ml, we can remove the cannula and mark the area where till the swelling is present on it. After this, we have to apply, if it's a DNA, since it's a DNA binding agent, we have to apply cold compression to localize the drug. Also, since it's an anthracycline, we can apply DMSO. Also, dextrazoxane is also indicated in case of anthracycline.
Okay.
And
So
uh,
I would like to interrupt you. How will you give cold compression?
cold compression is given for up to 30 minutes to 6 hourly for 2 to 3 days.
Yeah, good. And how will you give DMSO?
DMSO, it's 140 ml divided into 1 ml syringe. Sorry.
Yeah. So DMSO is 4 drops per 10 10 centimeters square. Okay. Okay. And how will you give dextrazoxane?
Dextroxane 1000 milligram IV on day one and day two, and 500 milligram IV on day three.
Yeah, and it should be given within 6 hours of the extravasation, right? And what is
Yes.
the mechanism of action with dextrosuxine?
Dextroxane is an ion chelator. It will prevent free radical related injury by anthracyclines.
Yeah, it's a free radical scavenger as well, right? Okay. So in case of DNA non-binding vesicle, how will you manage it?
DNA non-binding, we have to disperse the drug, like in alkaloids, we have to apply hot compression, and it improves. Also, hyaluronidase can be applied uh, in 1 ml syringe in 5 different quadrants around the. So mark the area and look for any progression of the
Yeah, and
extravasation.
so you use this hyaluronidase, which comes in a 10 ml bottle. 1 ml is equal to 150 units, and for every 1 ml extravasated, you give 1 ml of hyaluronidase, right? Uh, so that's how you give the dose. For every 1 ml extravasated, you give 1 ml, which corresponds to 150 units of hyaluronidase. Okay. So can you just tell me what are some DDs of extravasation?
Uh, it
Yeah.
could be any infection on the site. Uh,
Okay. So yeah, it can be phlebitis, for example. It could be a flare reaction, or it could be a venous shock. If it is there, that can also simulate extravasation. Okay. Before we move on to the next one, um, can you tell me what will we use for cisplatin extravasation?
this matching is an irritant, sir. Can
Yeah.
uh, just give supportive care and dispose of the drug.
Yeah. So we'll give you use sodium thiosulfate is used. Okay. So yeah, I mean, you answered all the important questions. So good. We'll now move on to our next case. This is what you expected to answer, what Dr. Vaishak said. Um, okay, now we'll go to the next question. It's for Dr. Raja. Uh, this patient was on treatment for metastatic colorectal cancer, and he presents to you after the second cycle with these features. Can, uh, can you identify what this is?
This is HFS, hand-foot syndrome.
Okay, HFS, right? Can you tell me what are the various mechanisms of action of hand-foot syndrome?
Sorry, sir.
Can you tell me the pathogenesis of hand-foot syndrome?
The drug gets accumulated in the dermis, and then there is peeling off of the dermis, and there is also because of the microvascular injury.
Yeah. What are the reasons? As in so I'll just quickly mention that. Basically, if you know this thymidine phosphorylase enzyme, right, which is the activating enzyme for example, capecitabine, that is present in high amounts in the hands and feet, which is why it gets activated, right, to fire fuel. So that is one cause. Another cause is that temperature, right? So there's increased blood flow in the extremities that can also cause hand-foot syndrome, especially on exposure to heat. Um, Another thing is higher concentration of eccrine sweat glands, to which certain drugs can bind and increase hand-foot syndrome. What are the drugs that can cause this?
Capecitabine and 5-fluorouracil,
Can you name a couple more?
uh, doxorubicin, liposomal doxorubicin,
Yeah,
cytarabine,
yeah. So you're right. Capecitabine, liposomal doxorubicin, 5-FU, cytarabine can also cause, right? So those are some of the causes that you see. Um, what is the difference between hand-foot skin reaction and hand-foot syndrome?
So in hand-foot syndrome, it will be diffuse. Hand-foot skin reaction is more localized, and hand-foot syndrome reaction occurs due to microvascular injury. So you will find the hand-foot skin reaction in those dependent those parts which gets frictioned up, like in the calluses or in the toes, and it is can be asymmetrical. HFS will be symmetrical and diffuse.
Okay, can you tell me some of the drugs that can cause hand-foot skin reaction?
Hand-foot skin reaction caused by the pen TKIs like sorafenib, pazopanib, lenvatinib.
Yeah, so I'll just so the TKs that inhibit both
Sorafenib.
EDGFR and VEGFR. Okay, so you're right with sorafenib. regorafenib, cabozantinib, sunitinib. Okay, so these are the ones. They inhibit both VEGF as well as PDGFR. So those can cause hand-foot skin reaction. And like you rightly said, it occurs in places where there's friction exposure, right? Um, so usually it's more localized to the feet, whereas hand-foot syndrome is more towards the palms, right? Okay. Now, moving on, what are the grades of hand-foot skin reaction?
Uh,
Hand-foot syndrome?
in grade 1 there will be minimal skin change, there will be no pain, and there will be no functional limitation. In grade 2 there will be skin change, there will be pain, and there will be limit to the instrumental activities of daily living. And in grade 3 can be severe pain, and in grade 4 can be bleeding or blistering.
Yeah, okay. So, as per the NCI, there are three grades. Okay, so you're right. Grade one is minimal skin changes without pain. Grade two is skin changes with pain, affecting the instrumental activities of daily living. So, for example, going shopping or managing your, accounts, or, going for a movie, etc. But grade three is when you have skin changes with severe pain that can affect your self-care activities of daily living. Okay, so three grades are what we commonly quote based on the NCI grading. Okay. Now, moving on, what are some of the precautions you can take to prevent hand-foot syndrome?
Mm, we can ask the patient, first of all we'll ask them to maintain the hygiene of the limbs, and if there is a we'll ask them to apply moisturizer,
So, what
urea
sort of
cream,
moisturizer will we give?
uh,
Urea based, right?
urea based, yeah, urea cream.
Anything else we can give? Yeah, I'll just fill it in there. We can give pyridoxine, right? And celecoxib as well, prophylactically. We can also give, based on which Indian trial? What drug?
Diclofenac gel we can give 2% based on some AIMS data. I don't know the trial was.
Yeah, the DTORCH trial. Okay.
Torch.
So, those are some of the prophylactic measures for hand-foot syndrome that we can take. Okay, so those are the questions they tend to ask regarding hand-foot syndrome. It's very commonly kept. Okay, so now next question goes to Dr. Sriram. Can you identify what could be the possible cause here?
Uh, yes, I can see an ulcer in the right lateral border of tongue.
Is it just an
Uh,
ulcer?
no, it's a malignant ulcer, like the
It's an ulcer proliferative
car-
lesion, right?
ulceroproliferative lesion in
So
the
what could be the cause?
right lateral border. It's a malignancy, possibly tobacco related
So
or,
what
or
malignancy? You
HPB.
have to be specific. So carcinoma
The
tongue.
squamous cell carcinoma tongue, yeah.
Yeah. Okay. So when you're talking about ward rounds, right, you have to go straight to the diagnosis. It's not like case presentation. Okay. So squamous cell carcinoma of the tongue is the most probable cause. Okay. What is the treatment plan for this particular patient?
For this patient, it looks like the only lateral is involved. Like, we'll examine the patient first and do a complete metastatic workup. Like, treatment plan will be like, I will discuss with the patient, and I'll also discuss in the MDT, and like, if it is operable, then I'll go for like means neoadjuvant immunotherapy with like, then followed by which I'll do surgery, and for post-op I will plan for concurrent chemo RT based on the stage, and then continue immunotherapy for a total of 1 year.
Okay, fine. As per latest keynote 689, you can, uh, uh, oral cavity cases, especially where you're undergoing resection, you can give neoadjuvant immunotherapy, pembrolizumab for 2 cycles, followed by surgery, followed by CT or RT if required, RT if required, and concurrent chemotherapy if required, with adjuvant pembrolizumab up to 1 year, right?
1 year.
Okay, so you can say that, or you can give your institute protocol, whatever you're following. Okay, now please tell me what are the indications for adjuvant RT in this case?
So T3, T4 disease is an indication. Then presence of positive margin. Then means presence of means basically more node positive disease, like more than say one node positive. Then there is like LVI PNI positivity. Then if it is like inoperable or means
Yeah, so I'll just quickly
They're
tell you.
not
So
like
the high risk features are extracapsular extension. You can have presence of margin positivity. Those are the high risk features. The other features are, like you said, T3, T4, LVI, PNI, worst pattern of invasion 5. Uh, all those can be reasons to give adjuvant RT. In which scenario will you give concurrent chemotherapy?
concurrent absolute indication is margin positive and N3 disease, N3B disease,
Yeah, so
extranodal.
extra capsule extension and margin positivity. Okay, what agent will you give?
Question. First.
What agent will you give?
I'll give like cisplatin.
Okay, what are the two
Concurrent cisplatin.
the dose regimens of cisplatin that you know?
So one is a 3 weekly regimen where we can give 100 mg per meter squared, or we can go for weekly
100 mg per
40
meter
mg per
square? Okay, 3 weekly. Then?
and 40 mg per meter squared weekly.
Okay, weekly. Good. Okay, so what are the other regimens that can give concurrently? Say this patient has a creat clearance of 30.
So other drugs can be like we can give concurrent cetuximab.
What is the dose?
Uh, it's given 400 mg per meter squared at the first dose, and after that weekly it is 250 mg per meter squared.
Yeah, so 400 milligram per meter square is given 1 week before starting RT. Okay, and then 250 milligram per meter square weekly. So you're right. Any other dose that you any other chemotherapy agent that you can give?
We can also give
Yeah, so I think there's some yeah. Can you hear me?
Tata trial for docetaxel. Yes, boss. Tata trial is there for a concurrent docetaxel also,
What is the
and
dose?
there is that is 50 mg per meter.
15,
Exactly
15, 15,
15
15
mg
milligram per meter square. Okay.
meters. Yes, boss. And then we can also give nimetosumab. That also trials are there.
Yeah, that is also anti-EGFR inhibitor, although the data is kind of weak for that. Okay. So this is generally what they'll tend to ask you. They keep a CA oral cavity case. If you can say this much, I think that is enough. Okay. Uh, okay. So the next question goes to right. So Dr. Poonam. Okay. So
Yes.
this is a 3.5-year-old child who has undergone a surgery. What could be the probable diagnosis here? The patient presented with an abdominal mass, and apart from that, the patient was had no other symptoms. Underwent surgery. What could be the possible diagnosis here?
So first possible diagnosis will be neuroblastoma or
Why neuroblastoma?
abdominal lump in children less than around 3 years of age will be uh, first diagnosis will be neuroblastoma.
Yeah, so
Wilms tumor. Wilms tumor.
always say Wilms tumor first. Okay, like I said, it is an abdominal mass. The patient had no other symptoms. If you have a sick child with fever, with severe pain, and other associated syndromes, then you can consider neuroblastoma. Also, neuroblastoma is seen in age less than 2 years. Okay, this is a 3.5-year-old child, right? So more in favor of Wilms. Okay, so can you tell me the difference between neuroblastoma and Wilms tumor?
Yeah.
What all differences do you know?
In the imaging, we can
Start off with the age.
Yeah. Wilms tumor will be 3 to 5 years of age, and neuroblastoma will be less than 2 years. And 2% cases we can get in older children also, like more than 2 years. And most commonly, seen in Japan in the neuroblastoma cases, where most prevalent there. So screening for neuroblastoma is done there, and no such screening tools for Wilms tumor worldwide. And
Okay, so that's not that important of a point. Just
yeah.
mention the important points. Okay.
Then boss, their imaging features we can diagnose, we can differentiate. Like in neuroblastoma, the mass will be irregular and with calcifications, and the margin will be irregular, and it can cross the midline. Whereas the Wilms tumor, it doesn't cross the midline, and it is very smooth, and there is no calcifications over the mass. And in neuroblastoma mass, it sometimes lifts the vessels away from the origin, where the Wilms tumor doesn't lift the vessels away, and in the MRI. T1 in T1 weighted images, the neuroblastoma is hyper intense. In T2, it is a hypo intense, and in Wilms tumor, in T1 and T2 both will be hypo intense.
Okay, so I'll just, you have mentioned a lot of points. I think that is good enough for an answer. I'll just summarize it. Okay. So, Wilms tumor, 3 to 4 years of age, neuroblastoma, less than 2 years of age. Wilms tumor present with an abdominal mass, but rarely has constitutional syndromes. Neuroblastoma will have a painful abdominal mass. They'll have constitutional syndromes and other, syndromes associated as well. The patient, it will basically be a sick child. Okay. Or organ of origin is kidney in Wilms tumor, whereas it is the retropetal neural crust in case of neuroblastoma. There's claw sign seen on CT in Wilms, no claw sign on neuroblastoma. Calcification is less than 15% in Wilms, whereas more than 85% in neuroblastoma. Wilms tumor rarely crosses the midline. Neuroblastoma crosses the midline. Wilms tumor invades vessels, whereas neuroblastoma encases vessels. Mets in Wilms tumor seen to the lung, liver, and lymph nodes, whereas in neuroblastoma it's seen to the bone, bone marrow, skin, and liver. Okay. Um, so that's the basic thing. And of course, prognosis is much better than Wilms tumor compared to neuroblastoma. Okay. So these mean symptoms, if just basic features that you need to say. Don't mention any screening or anything like that. The examiner might get annoyed because they themselves won't know that. Okay. So now, can you tell me what are the two ways in which they treat, what are the two, ways in which they treat Wilms tumor in Europe and in America?
Europe, there is Kojic regimen.
Okay, I'll quickly step in. So in Wilms tumor, you have two types. Okay, American in America they treat with the COG protocol, and they do upfront surgery, and then based on the histopathology they give adjuvant treatment. Okay, whereas in Europe they use a SIOP protocol where they give neoadjuvant treatment, then do surgery, and based on the histopathological response they give adjuvant treatment. Okay, so those are the two different protocols that they use. Now. For I'll just quickly go through the treatment protocols. Just know the basic regimen. That's it. You don't have to go in beyond that. So very low risk, standard risk, higher risk, high risk, and highest risk. There's 6 classifications based on COG, right? Now, for very low risk, that is stage 1, less than 2 years or less than 550 grams, you'll just do surgery, nephrectomy alone. For low risk, that is stage 1, greater than 2 years, greater than 550 grams, right? With no loss of heterozygosity in 1p 16q, you'll do surgery and give vincristine and dacnomycin. Okay. In standard risk, which is stage 1 and 2 with loss of heterozygosity, or stage 3 with no loss of heterozygosity, or stage 4 with no loss of heterozygosity, with rapid response of lung mets at week 6. Okay. That is, lung mets have disappeared at week 6 after giving neogen. So stage 4 will give neogen treatment regardless of COG or SIO. Lung mets have rapidly, decreased. As there is a CR at week 6. For all of this, you'll do surgery. You'll give adjuvant VAD. So that is vincristine, actomycin, and adriamycin. And you'll also give RT in stage 3. Okay. Stage 3 and stage 4, you'll give radiation as well. And coming to higher risk is stage 3 with loss of heterozygosity, or stage 4 with loss of heterozygosity. So there you will give surgery, you will give adjuvant radiation, and you'll also give this VAD, right? Alternating with cyclophosphamide and etoposide. Okay. And then you've got high risk and highest risk, that is presence of anaplasia or diffuse anaplasia. Okay. So there you'll give something known as regimen UH2. Okay. So they'll do surgery followed by adjuvant RT with vincristine, right? Doxorubicin, cyclophosphamide, alternating with carboplatin, etoposide, and irinotecan. Okay, so that is how you treat. If they ask you the treatment of Wilms tumor, just mention this in a flow. They'll stop you somewhere midway and go on to the next question. Okay, just what all I've told you, just remember that. Okay, that is enough. You need to know the two types, IOP and COG, and you need to know, I've mentioned COG right now, how it is given. Okay, that is all you need to know. That is what the examiner is asking, expecting from you. Always remember, difference between Wilms and neuroblastoma, definitely they'll ask. Okay. So now moving on to the next question, we'll go to Dr. Chandana. So this is a 60-year-old. She presents with proptosis of the left eye since the last 6 months. Okay, what could be the DDs in a 60-year-old with proptosis?
Sir, it could be a lymphoma.
Okay, what sort of lymphoma? Yeah, so you mentioned lymphoma, you're right. So usually it will be a low-grade lymphoma, okay, like a maltoma. That's what
Yes.
you commonly see when you have orbital proptosis. What else can cause this in this particular age group? Yeah, so I'll clue you in. It can be a plasmacytoma that can cause this, right, in a 60-year-old. It can also be metastasis. It could be from the thyroid gland. If it is a female patient, from the breast, right? So all that can metastasize to the orbit. Um, Rarely in this elderly age group, you'll get rhabdomyosarcoma, although that is very rare. You'll get it in a younger patient with proptosis, right? And also you can have an optic nerve glioma or a lacrimal gland tumor that can also cause proptosis. Okay. So now can you tell me the treatment for, I would like to know the treatment for, suppose you got a maltoma, right? You got a
Yes.
patient with proptosis, you have done an MRI of the orbit, you have taken a biopsy from there, it has come out to be maltoma. How will you work up and manage this patient?
For maltoma, only if the patient is symptomatic, we can go ahead with
So is this patient
treatment.
symptomatic? He is definitely symptomatic, right? He has proptosis, right? Also chemosis of the eye. So what we will do is in a maltoma, you will do a workup. So you'll do a PET CT, okay, or a CT thorax abdomen pelvis. PET CT might not have that much uptake for an indolent lymphoma, and you'll see if there's disease elsewhere, okay. And you'll also would like to do a bone marrow biopsy to see if there's any bone marrow involvement. If the disease is confined to the orbit, like it mostly is, well, that's what we mostly tend to see. You can give radical radiation to the orbit, and then that is done with curative intent and keep the patient on follow-up. Okay, so that's how you manage that. Um, okay, so just remember the DDs and remember just know the treatments for that. Also, plasmacytoma, you'll give radical radiation, right? Then rarely you can like breast cancer in females or thyroid can also metastasize to the orbit, and you'll also have some other cause like optic nerve glioma that I mentioned. Okay, so moving on to the next question, right? Okay, so yeah, Dr. Praneeth, can you tell me what this is? What are we looking at here?
Sir, we are looking engorged veins over the chest and the hands and over the neck.
Yeah, what could this signify?
Sir, it would signify mostly SVCO, sir, superior vena cava obstruction. Uh,
Yeah. Okay. So
mostly
you're right.
heterozygous.
This is what should come to your mind when you see a case like this. You can see that you'll have facial edema, you'll have edema of the upper limbs, you'll have engorged veins. The patient will be dyspneic, right? The patient might be cyanotic. So all these features, if you see, you have to think of SVCO. They might not keep an actual patient, but they might keep an image or something like that. So it depends on what is available at that time. Can you tell me the most common cause, malignant cause for SVCO? The top three.
So top three, first would be lung cancer, non-small cell lung cancer, small cell lung cancer, a lymphoma, and a mediastinal tumors like thymoma.
Yeah. So number one is lung cancer. You're right. Small cell lung cancer is a higher propensity to cause. Okay. Followed by non-small cell lung cancer because not small cell is more central mass and they're fast-growing tumors, right?
Yes, sir.
So second is like you're right, lymphoma, and third is actually metastasis. Okay.
Okay.
So can you tell me what sort of lymphomas can present with a mediastinal mass that will cause SVCO?
Sir, DLBCL, primary mediastinal B-cell lymphomas.
Yeah.
NHL, most commonly to NHL will cause SVCO, sir.
Yeah, so primary mediastinal B-cell lymphoma can cause, lymphoblastic lymphoma can cause, especially in young children, T lymphoblastic lymphoma to be specific. And also you can have it in, Hodgkin's disease, although that is slightly rare, it won't present with SVCO. But you're right. NHL definitely, PMBCL, lymphoblastic lymphoma, and rare cases, nodular sclerosing variant of Hodgkin's. Okay. Although that is, Hodgkin's generally doesn't tend to present with SVCO. Okay. And other malignancies like, germ cell tumors, if you have a thymine malignancy, a mesothelioma, etc., that can also cause. Okay. What is the most common, in an oncological context, what is the most common non-malignant cause of SVCO?
Non-malignant cause of SVC.
Yeah, so you can
Thrombus.
have a central venous catheter thrombosis, right?
Thrombus.
Yeah, or you can have a non-neoplastic thrombus as well. That can also cause. Okay. Can you tell me about the classification of SVCO?
Sir, SVCO, we have use classification, which is graded, sir. In grade 1, patient will be, radiologically there will be SVCO, but clinically patient would be asymptomatic. Grade 2 would be patient would be having facial swelling, plethora, and engorged veins, but no heart failure. Grade 3, where patient might be having cerebral edema, mild cerebral edema, mild heart failure with facial plethora and facial swelling. Whereas in grade 4, patient will be having severe heart failure, severe cerebral edema, along with grade 1 and grade 2 features.
Okay, yeah. So use classification divided, it's a clinical classification. So divided to grade 0 to 5. 0 is asymptomatic. Grade 1 is mild features of plethora cyanosis and head and neck edema. Grade 2 is grade 1 plus functional impairment. Grade 3 is, like you said, severe. So there is mild to moderate cerebral edema, laryngeal edema, or limited cardiac failure. Grade 4 is life-threatening, severe cerebral edema, laryngeal edema, and congestive heart failure. Grade 5 is fatal, right? Is there any other classification you're aware of?
Sir, I know Doty classification, sir.
Yeah, Doty and Stanford, right? Can you just quickly tell
Doty.
us?
Sir, in Doty, it is mainly radiological, depends upon the stenosis of the superior vena cava. We have 4 in that, type 1, type 2, type 3, and type 4. Stenosis up to 90%, less than or equal to 90% is type 1. If it is more than 90%, it is type 2 of supraazygous. Whereas complete occlusion of SVCO with azygous reverse blood flow, it is type 3. Whereas in type 4, it would be occlusion of SVCO with involvement of major tributaries of azygous vein.
Yeah, so there'll be collaterals that will come up, right? Okay, so that is an anatomical classification. You said that perfectly. So when a patient comes to you with SVC, how do you manage that patient?
Sir, if a patient is in grade 1, grade 2, and grade 3, we'll see
As in, they've come to the casualty, what will you do?
So, if the patient has come to casualty and if the SOCO is grade 1 and grade 2, grade 3, if it is from grade 1 to grade 3, we'll first go for staging evaluation and tissue biopsy, and then we'll see whether the tumor is radiosensitive or not, or whether it is chemosensitive. According to that, we'll proceed, sir. If otherwise, if the patient is presenting in grade 4,
You mentioned
immediately we will,
radiological investigations. Anything else you'd like to do?
so radiological investigations we'll do.
Apart from that,
See,
okay, imaging you have done, you also need a biopsy, right?
yes, sir.
Yeah, biopsy
Tissue
is also.
biopsy also is required.
Yeah. Okay. So continue. Yeah.
If patient presents with grade 4, sir, then we have to immediately stabilize the patient, either by first providing either immediate stenting of the SVCO, maintaining the airway, and that we have to first stabilize the patients and then evaluate for what is the disease, like
Yeah.
imaging and all.
Yeah. So basically, you're more or less right. So any SVCO case, you have to manage symptomatically first, stabilize the patient first. Okay, that's what you should say. Number one, stabilize the
Okay.
patient. Only do lower limb cannulation, give oxygen, give your bronchodilators, uh, whatever is required, symptomatic care, and then you do imaging and you do a biopsy. Okay, do that as quickly as possible so we don't wait around. And then, based on the initial biopsy, right, you can also start the patient on steroids as well after you've taken the biopsy. And based on the initial biopsy report, which you asked to obtain quickly, you look at the radio and chemosensitivity of the tumor. So if you have, tumors like lymphomas, they can be managed with chemotherapy alone. Once you start out the steroids, they'll respond, right? If you have, for example, something like a lung cancer or something of that sort, then you can give palliative RT to the mass, or you can give chemotherapy as well along with that, right? Then of course, like you mentioned, if it's grade 4 use, like it's life threatening, there we might need to do immediate stenting. Okay, so you're right about that. So that is how you'll more or less manage a case of SVCO that presents to you. Okay. You look at biopsy, you stabilize the patient, do imaging biopsy, look at the histology, give chemotherapy alone or chemotherapy plus RT, or if it is life threatening, you'll go for stenting right away. Okay, so I think that about sums it up regarding this particular case. Okay, right, we'll move on to the next one. Okay, Dr. Karamveer. So this is a patient who was on treatment for breast cancer, and they came to you after 1.5 months like this. What are we looking at here?
It is alopecia, sir.
Yeah, so chemotherapy-induced alopecia, right? So
Yes,
what
sir.
are some of the drugs that can cause chemotherapy drugs and targeted drugs that can cause alopecia?
The chemotherapy drugs like adriamycin, alkylating agents, sir, and targeted agents like CDK4/6 inhibitor, sir, in this patient, like
Yeah, so we'll
palbociclib.
just finish up chemotherapy. Like you said, topoisomerase inhibitors like anthracyclines can cause, alkylating agents can cause, uh, also antimicrotubule agents. Okay, so your taxanes can cause as well. And the remaining chemotherapy like antimetabolites is less commonly seen. Okay, so mainly it is antimicrotubule agents and anthracyclines and other topoisomerase inhibitors. Okay, followed by alkylating agents and very rarely with antimetabolites and other agents. Okay, so targeted therapy, can you tell me?
The CDK4/6 inhibitor, palbociclib, sir.
Okay, anything else?
So TKI, sir.
Yeah. Okay, so I'll just, you're right. CDK4/6 inhibitors
Sir,
can
also
cause.
ADCs, sir. ADCs like TDXD, TDM1, sir.
Okay, not so, yeah, I mean, not all ADCs can cause, but yeah. So I'll just quickly summarize that. Okay, like you said, CDK4/6 inhibitors can cause thinning of hair. Um, then your, what do you call it? Your VEGF inhibitors like sorafenib, regorafenib, pazopanib, cabozantinib, all that can also cause thinning of hair. BRAF inhibitors can cause, right? Your BCR-ABL inhibitors can also cause to a certain degree, although it is very mild. And of course, your what do you call it? Certain ADCs can cause the TDXT and all, but it's very mild. Okay. So those are the just mentioned 3, 4 agents when they ask you this question. Okay. Can you tell me what is the role of
Scalp cooling.
scalp cooling? Yeah. So what is the mechanism of action there?
Sir, exact mechanism is not known, but actually they cause vasoconstriction there. So less drug will goes to the hair follicles. So less damage will be there, sir.
Okay. Can you tell me an FDA approved scalp cooling system?
So, name nahi pata, sir.
Yeah, a DigniCap. Okay. So you have DigniCap and Paxman scalp hypothermia system. Okay. So what is the temperature here that we use in scalp cooling? So usually we apply it 30 minutes before, and these FDA approved ones are automated scalp coolers. Okay. And so 30 minutes before chemotherapy is given, and the temperature that is applied, um, right. So the temperature that is commonly applied is 0 degrees to 3 degrees Celsius. Okay. And so can you tell me, so 30 minutes before and also
During
during
therapy,
chemotherapy and 90 minutes after chemotherapy, you have to maintain a temperature of 0 to 3 degrees Celsius. Okay. What are the contraindications of using scalp cooling?
sir, if there is presence of skin disease like dermatitis
Okay,
or
fine.
uh,
Yeah, so I'll just finish that off for you, right? The dermatitis in children, it's not approved. In hematological malignancies, okay, because you can't restrict chemotherapy flow to a particular area, and if the patient has cryoglobulinemia or cold agglutinin disease or anything like that, you cannot give. Then of course, you know, uh, if the chemotherapy agent is a continuous infusion, for example, 5-FU, right? 24, 46-hour infusion, there also it's not approved. Okay. Okay, so that is regarding alopecia. Okay, can you also tell me do you know any grading systems for alopecia?
uh, Sir, less than 50%, more than 50%.
Okay, so you have something called the Dean scale. Okay, grade 0 is no alopecia, grade 1 is 0 to 25, grade 2 is 25 and above to 50, grade 3 is 50 to 75, grade 4 is above 75. Okay, so that's the Dean scale. You also have the CTCA grading. So study one of those. Okay, okay, I think that's it for alopecia. Now we'll move on to the next one. Okay, but this question goes to Dr. Salahuddin. Okay, you there?
Hello. Yes, sir.
Yeah, okay, cool. Can you tell me what we are seeing over here?
Sir, we are seeing oral mucositis.
Okay, yeah. So, in the context of malaria, some treatment-related oral mucositis, right? So,
Yes,
can
sir.
you tell me, are you aware of the WHO grading for mucositis? WHO or
Mm,
CTCA, any one of those?
so CTCA, the grade are there, sir, 0 to 4. So 0 is there when sir, there is mild mucositis which does not hamper the oral intake of the patient.
Grade 0 is not there. We have to start off from
Grade
grade
1,
1.
sorry.
Yeah.
Grade 1 is there. When there is it does not hamper the oral intake of the patient. Grade 2 is there when it hampers the patient is able to take liquid food. Grade 3, patient is not able to take liquid food also. And grade 4, it is um,
Yeah, life-threatening urgent intervention is required, right? So
yes, sir.
CTCA is, like you said, is grade 1 asymptomatic, mild symptoms, and no intervention is required. Grade 2, it is the patient has moderate symptoms or pain, and it is not interfering with oral intake. Grade 3 is if you have severe pain interfering with oral intake, and grade 4 is life-threatening urgent intervention required. Okay, you can also study the WHO score as well. You can just look into that.
Yes, sir.
Now, what can you tell me some of the in oncology, right? What are some of the treatments, uh, systemic and local that leads to mucositis?
Sir, in oncological treatment, which can lead to mucositis, can be either radiation therapy, which involves the oropharyngeal area, or which can be a cause. Secondly, it can be due to chemotherapeutic drugs,
All right.
which can cause. Thirdly, it can be due to targeted therapies like TKIs, which can also cause these
Okay,
symptoms.
so which sort of chemotherapy agents commonly cause?
So generally, this is caused by chemotherapeutic drugs like anthracyclines,
Okay.
or it can also be caused by drugs such as cyclophosphamide or methotrexate. Antimetophylates like methotrexate, pemetrexate can also be a important cause for these kind of symptoms.
Yeah. Okay. So capecitabine 5-FU, anthracyclines, low dose methotrexate, right? So capecitabine 5-FU, anthracyclines, low dose methotrexate. Irinotecan can also cause, etoposide can also cause. And like you mentioned, biological agents like anti-EGFR TKs especially. Okay. And anti-EGFR TKs and anti-EGFR MABs like cetuximab as well. Okay.
Yes.
So, okay, good. Let's move on to the next point of discussion. Can you tell me how will you manage a case of what are some of the methods with which we can manage a case of you can prevent mucositis? We'll start off with prevention first.
Yes, sir. We can prevent the oral mucositis by asking the patient to comply with good oral hygiene during the course of chemotherapy. They should use oral mouthwashes regularly while they are on chemotherapeutic drugs. Along with that, we can advise the patient to use ice chips while the patient is taking chemotherapy. So this reduces the blood flow to the oral mucus area and causes decrease in chemotherapeutic drugs being delivered there, and decreased these kind of side effects.
Okay, yeah. So apart from that, do you know any other agents that can be given?
Uh, there is a drug, sir. I can't recall the name right
Yeah.
now.
Okay, I'll just so you're right. You mentioned the two most important things. You can also give amifostine. Okay, so amifostine is usually given in the auto transplant setting, especially prior to melphalan and myeloma, right? And also in beam with lymphoma. So there you give 1,000 milligram per meter square on day of conditioning as a 15 to 30 minute infusion. Okay, and in RT you give 200 with radiation you give 200 milligram per meter square daily as a 30-minute IV infusion, 15 to 30 minutes before each fraction of RT. Okay, so that is amifostine. So basically, what it does is it detoxifies active metabolites of alkylating agents and scavenges reactive oxygen species as well. Okay, so that's how it prevents mucositis. Then you can also give low-level laser treatments are there with helium and neon-based lasers can be done along with radiation. That's usually given the radiation that can also prevent mucositis. Then also you have something called praliformin. Okay, so that is a recombinant keratinocyte growth factor, and that can be given prior to radiation and also prior to in case of auto transplant prior to giving the conditioning regimen. Okay, so all of that can be used to prevent this mucositis. Okay, so that's what they generally tend to ask. Now we'll move on to the next question. Okay, the next one. Good. Okay. Okay, we'll come back to. I think I've covered everyone there, right? So, so praliformin and radiation as well as in transplant. Okay. Okay. So now moving on, where do you see Dr. Vaishag? What do you see over here?
There is a flagellate rash usually seen with bleomycin.
Bleomycin toxicity, right? So, what are some of the other skin toxicities caused by bleomycin?
There can be hypopigmentation, nail toxicities. To a higher grade, ulceration can also be caused rarely.
Yeah, so you'll see keratosis, you'll see nail changes, you'll see striae across the skin, and this is the most characteristic presentation, that is hyperpigmented erythematous flagellated lesions, right? So around what drug dose do you see this?
Around 400.
200 units. Okay, 200 units around there you start seeing these toxicities. Okay. Now, also I'd like to ask you. So, right. So, what is the reason for these skin toxicities? This particular skin toxicity?
Is absence of bleomycin hydrolase enzyme in the skin as well as lungs. So the skin toxicity usually occurs due to this enzyme where bleomycin cannot be metabolized.
Yeah. Okay. That's the exact answer. Okay. So I think that's about it over here. You've answered most of the questions. Okay. So this is something that they commonly keep in the ward rounds. Okay. So this is a 62-year-old patient who presented with, who was on a patient of advanced lung cancer and was given some sort of oral medication, and then presented with, uh, this sort of skin symptoms. Okay. So what could be the cause? Dr. Raja, can you tell me? 62-year-old
Hello.
male. Yes.
Hello, boss.
Yeah. So 62-year-old male with skin lesions who was advanced lung cancer on oral medication. What could be the cause?
Boss, skin lesion, although it's not very much visible, I think some problem. It could be rash because of some EGFR TKI probably.
Yeah. So most commonly it will be due to an EGFR, multi tyrosine kinase inhibitor that inhibits EGFR, right? Okay. So what sort of EGFR inhibitors is it most commonly seen with?
So most commonly it is seen with generation 2 because they are pan TKI inhibitor like afatinib and dacomitinib.
Yeah, so you're right. So those strongly bind to both the wild as well as the mutated type of EGFR. It can also be seen with
Uh,
generation 2.
generation and first generation also.
Yeah, so first generation is both of these bind to both wild and activated EGFR, and mostly, like you said, generation 2 binds strongly to wild type as well. So because of that, it has high rates of skin toxicity, right? Which oh, what are the rates of EGFR skin toxicity with generation 3?
So I think it's around 30 to 40% skin toxicity.
Yeah, basically it is lesser, right? Even if you don't know the person, it's okay. It's lesser. Why?
Because no, don't know the answer.
Yeah, so like you said, it binds to only the more predominantly
Specific.
to the mutated EGFR, right? Rather than the wild. So that's why the skin toxicity is lesser. So in this particular patient, this patient has this acneiform rash all over the body. How will you manage this particular patient?
First of all, I will grade, like in grade 1 it is less than 10%, grade 2 10 to 10 to 30% of the body surface area. Grade 3 is more than 30%.
Yeah, this is
And
involving the entire body.
so it will be grade 3 to 4. So I will discontinue the EGFR TKI for 2 weeks and will give supportive care in the form of I will use topical antibiotic gel, uh, clindamycin. I can use oral minocycline tablets and what moisturizer and low dose steroid cream also.
Yeah, so low dose steroid creams, doxycycline is approved, doxycycline minocycline is approved in this indication, and you can also give some antipruritic measures as well. Okay, with that it recurs. Now the patient develops repeated grade 3, then you have to do a dose reduction of the TKI, right? And if the patient has grade 4, you will do a dose reduction right away, and later on if it comes up again, you might have to discontinue the drug, right? So this is also commonly kept, especially because EGFR is the most common mutation that we come across, right? So you should know about the diagnosis, what TKIs cause it, and what is the management. So good. Now we'll move on to the next one. Dr. Sriram, what do you see here? This
Uh,
is
just a malignant melanoma skin tumor.
okay, malignant melanoma, right? Okay.
Yes, sir.
So how will you manage a case of stage 2 malignant melanoma?
Sir, basically the first line treatment I'll means discuss in the MDT. Up to stage 2A, we can go ahead with direct surgery.
MDT discussion all is over. You tell me the management.
Okay. So up to sir, first my plan will be to get the tumor excised. Means then after that, like I will review the pathology report, and based on that, like if it is like stage 2B, then you have to consider adjuvant immunotherapy.
Yeah. So it's in stage 2B and 2C, adjuvant immunotherapy. What are the approved agents?
Adjuvant pembrolizumab.
Yeah. So
And
adjuvant pembrolizumab, adjuvant nivolumab for 1 year.
nivolumab.
Okay. Okay. Now suppose this is a stage 3 lesion. Okay.
Yes.
There's it's spread to the nodes as well. What will be your management there?
In that case, I'll consider a neoadjuvant approach. I'll give neoadjuvant immunotherapy for up to 3 cycles. Then, like later, reassess the patient for surgery and then continue.
Yeah, so basically,
management.
I'll just refine your answer. You have the Nadina protocol. Okay. So there you give 2 cycles actually, nivolumab and ipilimumab. You give 2 cycles, PD-1 and CTLA-4 inhibitor. Okay. You give 2 cycles 3 weekly, and then you do surgery at week 6. And if in PCR or MPR, you keep the patient on follow-up only. Okay. So if there's a CR or a major pathological response, then you keep the patient on follow-up. If there's no MPR or PCR, then you might have to continue with immunotherapy. Okay.
Nice.
Or if it is BRAF mutated, at that point, you would give a BRAF inhibitor.
BRAF inhibitor.
Okay. So if that is in the case of no MPR or PCR, so neoadjuvant immunotherapy is the treatment of choice currently in stage 3. Okay. Earlier, what were the treatments available prior to neoadjuvant immunotherapy?
In that case, like dacarbazine was available. Then there was
No,
interferon.
in stage 3, you had adjuvant immunotherapy, right?
Adjuvant. Okay.
Yeah, so you had adjuvant pembrolizumab, and you also had adjuvant nivolumab. And if the patient was BRAF mutated, you could also give dabarfinib and trametinib. Okay, that was earlier, adjuvant BRAF inhibitor or immunotherapy. Currently, the standard of care is neoadjuvant.
Neoadjuvant immunotherapy, and then 2 cycles, then again reassess the patient. After surgery, whether PATs here.
Yeah, so you good that you mentioned that. You said straight away. So that is the thing. It has changed now based on the Nadina trial. Okay. Right. Okay, I think we'll move on to the next question. Know your systemic therapy in melanoma. Well, they generally tend to keep this if they come across a case. Okay. Also, stage 4, I'll just quickly say, currently the standard of care in stage 4, regardless of BRAF mutation, presence of BRAF mutation, is dual and ICI. Okay, with nivolumab and ipilimumab. So that is the standard of care regardless of BRAF mutation. That has shown to have the longest overall survival. 10-year follow-up showed around 50%, above 50% melanoma-specific survival. So that is the management of stage 4. Okay. Moving on. Okay. Right. Okay. So, yeah, Dr. Poonam, can you tell me what the DD is here?
Boss, this is a case of retinoblastoma,
What are we seeing here?
white reflex,
Yeah, leukocoria, right? So,
leukocoria.
like you said, retinoblastoma causes. What are some other causes of leukocoria? Okay, so like Coats disease, if you have a cataract, if you have retinal detachment, right? Um, so all of that can cause leukocoria. So in case of retinoblastoma, right? Okay, so can you tell me the international classification of retinoblastoma?
Boss, there is a group A, group B. Group A, there is if the involvement is less than 3 mm from the choroid plexus and
Okay, so I'll just quickly say that.
post is
So, study the international classification. That's what's commonly used nowadays. Group A is small tumor, less than or equal to 3 millimeter in size in basal dimension. Group B is larger tumor, greater than 3 millimeter in size, or macular location, that is less than 3 millimeter to the fovea, juxtapapillary location, that is less than 1 millimeter to the disc, optic disc, and clear subretinal fluid less than 3 millimeter from the margin. Okay, or you can have group C, which is focal seeds, so subretinal seeds uh, that are less than 3 millimeter from the this thing, vitreous seeds less than 3 millimeter uh, from the tumor, and also you can have subretinal and vitreal seeds as well. That's group C. Group D is diffuse seeds, right? So subretinal seeds greater than 3 millimeter from the tumor, vitreal seeds greater than 3 millimeter from the tumor, or presence of both. And you have group D, which is greater than 50% of the globe is involved, neovascular glaucoma. If you have hemorrhage, vitreous hemorrhage, subretinal space hemorrhage, or optic nerve invasion, that is group B. Okay. So can you tell me, right? So for when you give adjunct care, so for group A to C, usually we give what do you call? We try to not do a major surgery, right?
okay.
So we try to do an
Local.
eye sparing local treatment. So usually you give neoadjuvant chemotherapy followed by an eye sparing local treatment. What is a neoadjuvant chemotherapy given?
Was it is a CV regimen we used to give. That is C is carboplatin and E for etoposide 5 mg per kg and V is vincristine
Yeah, I mean,
0.0.
even if you don't remember those, remember the agents. So there's
Okay.
use the CEV regimen. Okay. So for group A to C, you CEV regimen, and then you give local treatment. What are some of the local treatments that can be done?
Intraophthalmic artery melphalan.
You shouldn't say that in the beginning. So you should say cryotherapy, thermotherapy,
Cryotherapy. Okay,
right?
boss.
And also you can use plaque brachytherapy, etc.
Okay.
Right?
Okay.
Okay. So for group D patients, what is the treatment of choice?
Enucleation. Enucleation.
Yeah. So basically, you look at whether you can still salvage the vision.
Okay.
In that case, you can use high dose chemotherapy with a high dose chemotherapy, so that you use the same, like you said, CEV regimen, but at a higher dose, and then you can give aggressive focal therapy. Okay, so that is an option. But usually, if the vision is lost, especially with group D, you do enucleation, right? You do enucleation.
Enucleation and 6 cycle of VAC regimen.
Yeah, yeah. So that's what you do. So group E, you do primary enucleation in all cases. Okay.
Okay.
So that is the management of retinoblastoma. Can everyone mute themselves, please? Yeah. So, okay, so that is the basic management. So just know the basic management, know leukocoria, what the DDs are, know the chemotherapy regimen that is used. It is CEV regimen. Okay. That's what they'll tend to ask in this setting. Okay. Okay, cool. So now I think we'll move on to the Grand Viva section. This will also cover some things that can be asked in war downs as well. So there might be some interchanging. Okay. Okay. Okay, great. So now let's move on to the next part. Okay, so you have a 20-year-old male patient with complaints of mandibular swelling, since 1 month with rapid progression in size. FNAC and histopathology of the lesion show the following. Um, okay, Dr. Praneeth, can you tell me what you're seeing here?
Sir, towards the left, we can see a peripheral smear with a large nucleus eccentrically placed cytoplasm with multiple nucleoli, mostly representing ALL L3 type. Mostly it is a Burkitt's leukemia.
Okay, so
And on left side, it is most
yeah.
often like a bone marrow thing, sir, showing multiple steric appearance.
Okay, so I'll just refine that. This is all taken from a mandibular swelling. Okay, there's no bone marrow that is seen here. So in the first thing is an FNAC. So the FNAC, you're seeing medium-sized, similar looking cells with a round nucleus, with a thin rim of basophilic cytoplasm, with intracytoplasmic lipid vacuoles. Okay, so that should point towards Burkitt's lymphoma. Okay, and next you're seeing a histopathology. So biopsy is taken. In the biopsy, you're seeing once again these small-sized cells, and along with that, you're seeing light areas as well. Okay, so giving a starry sky appearance. So biopsy of the mandibular lesion. So starry sky appearance, basically the light areas represent macrophages which have taken in the apoptotic bodies, right, of the tumor cells. So that is what you see here. So definitely it's Burkitt's lymphoma. This will definitely be asked. So can you tell me the histopathology that you generally tend to see in a Burkitt's lymphoma?
Sir, histopathology.
Sorry,
We
IHC,
see,
IHC.
Sir, IHC, it is CD19, CD20, BCL2 negative, BCL6 positive, CMYC positive, sir.
Yeah, so
And
it
K67 of 99 to 100%.
Yeah, so you're right. So you'll have B markers, CD19, 20, 79B. It's central in origin, so you'll have CD10 and BCL6, germinal center in origin, so you'll have CD10 and BCL6 positive. And usually here, BCL2 is negative and CMYC is always positive, right? So that is the presentation of Burkitt's. Okay, can you tell me the types of Burkitt's lymphoma?
Sir, we have endemic and epidemic type of
And
Burkitt's lymphoma.
immunodeficient type as well, right?
And immunodeficiency.
Yeah, so those are the three types. Can you tell me the principles of treatment in Burkitt's lymphoma case of chemotherapy?
Sir, principles, it should be of multi-agent chemotherapy, different drugs, different mechanism of actions, no interaction should be there. Each chemotherapy drug should have different toxicity profiles.
Okay, that's one point.
And patient should also receive CNS prophylaxis also, sir.
Okay. Okay, I'll just complete it. It should be, you're right, those 2 points stand, and it should be dose intense, right? That should be a high dose of chemotherapy should be given. It should also be dose dense, that is, there should be less interval between each regimen, and you should also give anti-TLS prophylaxis. And most importantly, it should be prompt. You should start treatment immediately, right?
Yes, sir.
Because there's a doubling time of 24 hours, so it will progress very rapidly. So can you tell me, like, how do you differentiate between low risk and high risk, Burkitt's?
Sir, we have Burkitt's IPA score, which includes age, age of the patient, performance status, LDH, and CNS involvement.
Yeah. Yeah.
Low risk, intermediate, and high risk. 0 to 0, it is 0 to 1, and 2 and 3, greater than 3, it is high risk, sir.
Yeah. Yeah. So basically, the risk status we need to know. See, you need to treat all cases of Burkitt's. The risk status we generally for prognostic perspective, you're right. You use your Burkitt's IPI. Okay. But from a treatment perspective, especially for the McGrath regimen, you divide low and high. So low is basically, if ECOG performance status is poor, if there's CNS involvement, if it's stage 3, stage 4, if there's LDH is raised, if there's all those, or the tumor size is greater than 10 centimeters, all those are, if any one of those are present, it goes into high risk, right? So that is for the McGrath regimen specifically. So if none of those are present, it goes into low risk. So as per the McGrath regimen for low risk, how do you treat?
Sir, actually, in our institute, we follow DIPOC-R, sir. So,
okay, I mean, that's fine, but specifically for McGrath regimen, if you can tell me.
Sir, McGrath, I have no idea, sir.
Yeah, okay, so McGrath, you give 3 cycles of R-Codox M, okay, for low risk, and for high risk, you give 2 cycles of interchange between R-Cordoxem and R-IVAC, and you give 2 cycles each of those 2 regimens. Okay, so 4 cycles in total. Okay, so that's Magad regimen. And other 2 regimens, can you tell me? You mentioned R-Diapoc, right?
Yes, sir. R diapoc or
Okay, that is another regimen. Can you tell me a third?
third, no idea, sir.
Yeah, so you can also use R-Hyper-CVAD. Okay,
Okay.
okay, good. Right. Okay, so the next question. 18-year-old boy presented to the OPD with bleeding nose and multiple spots all over the body. A peripheral smear showed the following. Okay, Dr. Karamveer, can you tell me what this could be?
So this is a peripheral blood smear, which is showing likely APML, sir, because of IU rods and
Yeah, so when you get a peripheral, don't say the diagnosis upfront. Okay, first describe the peripheral smear.
so this is showing WBC, likely immature. It is showing atypical WBCs, which is having IU rods in cytoplasm and granules in it, and the core cell cytoplasm, and nucleus is also prominent with a prominent nucleoli.
Yeah. Okay. So I'll just you've said most of the points. I'll just say basically you have these large cells with a folded or bilobed reniform nucleus, right? With granules in the cytoplasm, and also the in the nucleus the chromatin is finely dispersed, and the granules are arranged in the form of OR rods, which are bundled together. Characteristic appearance is that of a faggot cell, right? So this could represent abnormal promyelocytes. So this could point, along with the history, could point to a diagnosis of acute promyelocytic leukemia, right? So start off with the description, then go towards the diagnosis. Okay. So on a flow cytometry, what will be the findings in APML?
So it should be CD34 and GDT negative, HLA-DR negative.
Yeah, so that is you'll see the myeloid marker, like MPO, it is strongly positive, CD13, CD33 and all are positive, but HLA-DR and CD34 are negative, right? Okay, what translocation will you see here?
PML RARA, sir.
Yeah.
Translocation 15-17.
Yeah, good. Okay, great. So how will you approach this patient? You have done how will you got this in the peripheral smear? How will you approach this patient now?
Sir, I will immediately start empirical ATRA.
Good.
Then send PML RARA for confirmation of my diagnosis. And meanwhile,
will you straight away send PML RARA?
Sir, also stratify, also do rest of the tests, sir, like flow, bone marrow, and others, sir.
Yeah, so I'll just summarize it for you. So definitely, you've got an outside peripheral smear. It could be APML. You can, if you have any suspicion of APML, you should definitely give ATRA. Okay. Before that, you should do a CBC, DC, and bio. Right? You should look at the total count especially, because if the total count is raised and you give ATRA, it can cause differentiation syndrome. So do a CBC, DC first, then start the patient on ATRA if the total count is not too raised. The total count is raised, you can start on ATRA along with steroids. We'll talk about the significance of that later. Then you have to do a bone marrow. You have to do a flow cytometry to confirm that it is APML. You should do a coagulation profile, PT-INR and APTT, right? You need to start the patient on, if this based on the CBC and bio, you need to start the patient on platelets, FFP, etc., right? Especially the PT-INR is raised or fibrinogen is, altered, right? Then you should do an ECG and echo. You should do serum electrolytes as well, right? So all these features should come. You CBC, DC, peripheral smear, bone marrow flow cytometry, then ECG, echo, and electrolyte should be done, right? You should send your blood cultures. You should do a CT test to look for any infections, and along with that, concurrently, you should start ATRA, start giving your platelet transfusions and FFP transfusions, right? So concurrently, you should start treatment as well, basic treatment. Then what you do is you also, based on from the bone marrow sample, you also send FISH and PCR for PML RARA as well. Okay, so that is the diagnosis and starting of management go hand in hand in APML. Remember all these points. And what is the treatment of choice for low risk?
Sir, ATO and ATRA combination, sir.
Okay. So when do we do what is the dose?
So the dose for Atra is 10 milligram per meter square, and the dose
Is that too low, right?
45. Sir, 45 for Atra is 45 milligram per meter square, and for ATO is 0.15 milligram per kg.
Okay. Yeah. So you give that daily. And one more thing to note here is that when do we do revaluation?
Sir, after the hematological recovery, like
Yeah. So once the hematological parameters have normalized, that's when you do it, right? So we are talking about low risk APML. Currently, APML is divided into low and intermediate, low and high risk only. Currently. Okay, that is based on the total count, less than 10,000 on presentation or greater than 10,000, right? And low risk you'll treat, like you mentioned, with Atra and arsenic trioxide. And usually you do it till hematological parameters normalize. And you give at least 30 days of this. Following that, 30 days, and if the hematological parameters are normalized, then you do a repeat bone marrow. So what is consolidation that is given here in low risk?
sir, in low risk consultation is given with ATO and Atra.
Yeah, ATO and Atra only. Is there any maintenance in low risk?
So maintenance is zero to reason. Consolidation difference.
Yeah, so there is no maintenance in low risk. Okay. So if suppose the bone marrow after induction has come out to be in remission, less than 5% blast, but you do PML RARA as well. PML RARA is positive. Do you need to give some sort of reinduction or go for consolidation?
No, sir. We should recheck PML RARA.
It is not required actually. We just need morphological remission. Okay. If PML RARA is positive also, we should go to induction. Sorry, consolidation. Okay. So only morphological remission is required in case of APML. Okay. High risk, how will you treat?
Sir, in high risk, we can use ATO Atra along with idarubicin can be added, sir.
Yeah, so usually you will combine Atra with chemotherapy. Okay. So Atra plus this daunorubicin is what is given. Daunorubicin is is given a dose of 60 milligram per meter square, day 1, 3, 5, and if needed 7. Okay. So basically high risk is greater than 10,000 count. You need to decrease the count as soon as possible, because we know that if the count is high, these granules can break apart. There can be bleeding. There can be all sorts of complications. So we need to decrease the count. So there you give Atra and chemotherapy alone. Okay. Following that, you do a bone marrow. If it's in morphological remission, regardless of PML RARA, once again, you consolidate with Atra plus chemotherapy. Okay. Either with daunorubicin or cytarabine, depending on the protocol. Then there is maintenance as well. Maintenance is Atra, 6-MP, and methotrexate. Okay. Can you tell me what differentiation syndrome is?
So in APML, there is a differentiation block. When we give 8 differentiating agents like Atra and ATO, then these cells suddenly differentiate and cause capillary leak syndrome type features like shortness of breath, weight gain, and
yeah, so dyspnea, effusions, weight gain, etc., can be seen, right? So in high risk APML, what can we do to prevent that?
Steroids.
What do we give?
Dexa, sir.
Dexamethasone, what's the dose?
10 milligrams.
Yeah, okay. And once differentiation is certain, you get 10 milligram BD. Okay. So other complications that can be seen that they'll ask you is hyperleukocytosis, and also, pseudotumor cerebri can also be seen in form of headache. It's very commonly seen. Hyperleukocytosis is seen once the differentiation occurs when you give these agents, right? So the count can increase. Then one more thing is that you should always monitor, you know, you should do at least this, what do you call it? Every 2 to 3 days, you should monitor the CBC DC. Every 2 to 3 days, you should monitor the serum electrolytes, and at least initially bi-weekly and then weekly, you should monitor with ECG QTC interval, right? QTC interval and serum electrolytes when you give arsenic trioxide, right? And platelet count and even serum fibrinogen levels can be monitored. So that you should monitor and give PC and FFP accordingly. Okay, so that supportive care is very important, and monitoring of electrolytes, ECG with QTC interval, and your CBC is also very important. You need to do that continuous throughout the induction phase. Okay, consolidation and later on you need not do. So I hope you got that, how to manage low risk, how to manage high risk. They'll definitely ask this. Also the complications like differentiation syndrome and hyperleukocytosis that you see. Okay, and monitoring during treatment as well. Okay, okay, good. Let's move on to the next one. So this is for Dr. Ronak. Are you there?
Yes, sir. Yes, sir.
Yeah.
I'm here, sir.
Yeah, so you have a 70-year-old gentleman presents with generalized lymphadenopathy. Total count is 78,000 on evaluation. Peripheral smear shows the following. What could this be?
Sir, this could be there are increased lymphocytes here, and that could be a smudge cell, or it could be popcorn cell. A smudge cell is what I would think over here, sir,
So your
because of
diagnosis is?
CLL.
Yeah, so this is, like you said, you are seeing small lymphocytes here. They're small because they're the same size of an RBC, right? This is a peripheral smear showing small lymphocytes, same size as the RBC, that's increased. And you're also seeing these these small cells, they have, um, variable condensation of the chromatin uh, with a nucleus with a thin rim of cytoplasm, and the nucleus gives the appearance of a soccer ball cell, right? And also you see these smudge cells. Smudge cells are due to this, cytoskeleton fragility, which leads to smudging of the cell on processing, right? So that, right, this is along with the age, with the generalized lymphadenopathy and the total count, this is looking like a CL, right? Okay.
Yes.
Now, what is the definition of CL? How will you diagnose it?
So it's a chronic lymphoproliferative disorder with mature lymphocytes seen
What is the diagnostic
with
criteria? Yeah, be very specific.
monoclonal lymphocyte proliferation of greater than 5,000 cells or 10,000 cells.
Okay. Okay, I'll just tell you all the criteria. ALC, absolute lymphocyte count greater than 5,000, with pro lymphocytes less than 55%, that is lasting for greater than 3 months, right? And you also need to do a flow cytometry, which will be positive for CD5, CD19, CD20, and CD23, with cyclin D1 negative. So all these features combined, that's how you diagnose CLL. Okay, what are the conditions where you'll treat CLL? Do you treat all cases, and where would you like to treat?
So Binet and Rye staging usually, if they're having thrombocytopenia, if they're having severe organomegaly, and if they're having anemia, in advanced stages where they are symptomatic or recurrent infections, and then we would like to treat the CLL instead of observation.
Okay, so you mentioned some features, some of them you said are wrong. I'll tell you specifically what to say. Okay, if there is doubling of the absolute lymphocyte count in less than 6 months, if there is 50% increase in the absolute lymphocyte count within 2 months, okay, so that's a crown criteria. If you have thrombocytopenia less than 1 lakh, if you have anemia less than 10 grams per DL, that is there with DCT, ICT negative. Okay, so it is not autoimmune in nature. Or if it is DCT, ICT positive, and you have started the patient on steroids and it's not recovering even after giving steroids. So in those two scenarios, okay. Then if you have B symptoms, or if you have, hepatosplenomegaly or lymphadenopathy that is symptomatic or is causing an organ compromise. Okay, so in all these conditions, that's where you treat. There's no implication of stage or anything on treatment. Okay, okay. Now, can you tell me the first line treatment options in this setting?
So first line treatment, we want to know if you want finite or infinite treatment, and then
what is the standard first line treatment right now?
Standard first line, we could use ibrutinib-based BTK inhibitors, or we could use venetoclax BCL2 inhibitors based on affordability, and then cytoreduction. We could do some
venetoclax plus
venetoclax plus we could use enzyme inducer to decrease the dose of venetoclax.
I'll just tell you. Okay, so BTK inhibitors are standard of care, regardless of what. So earlier it was deletion 17p only. We gave BTK inhibitors. Now, regardless of the mutation profile, you should give BTK inhibitors in all patients. There's actually a PFS and OS benefit over chemo immunotherapy. Okay, so BTK inhibitors. Out of BTK inhibitors, what is preferred? You give second generation BTK inhibitors, acalabrutinib and zanubrutinib. Okay, because they have less toxicities compared to ibrutinib. Another fixed regimen that you can give is venetoclax and obinutuzumab. Okay, that is given for 1 year. Now, you might ask, what is the role of chemoimmunotherapy nowadays? Nowadays, you give it in patients who have IGH, if the variable region of the heavy chain is hypermutated, in those patients who are young with variable region of heavy chain hypermutated who prefer a finite treatment, there you can consider giving FCR even now. So FCR is fludarabine, cyclophosphamide, and rituximab. Okay, what is the dose of rituximab given in CLL?
375. We give a higher dose, 600 milligram per meter
So
square.
higher dose is right, but we give 500 milligram per meter square. Okay. So first, when you're giving chemotherapy, when we used to give it, we give cycle 1, 375 milligram per meter square. Then from cycle 2 onwards, you give 500 milligram per meter square. Okay. The reason for that is that CD20 is dimly positive. So it's not that strong. So you need a higher dose. Okay. So that's something they can ask you as well. Right. Okay. Let's move on to the next one. Right. This will go to Dr. Chandana. So a 45-year-old lady presents with early satiety and upper abdominal pain. Peripheral smear shows the following. What can you see here? Dr. Chandana, are you there? Okay, that's fine. We'll go to Dr. Poonam.
Milo.
Dr. Poonam?
Yes, boss.
Yeah, please describe this peripheral smear.
This is smear showing large promyelocytes and some eosinophils are there, and basophilia. Basophils are seen, then it is probably a smear of CML.
Okay, so you're right. Definitely there's a smear of CML. So just for the sake of exams, so when you get this case, this is how you present it. Okay. First of all, you say it's a peripheral smear because there are increased RBCs that you can see here. There are no fat spaces like a bone marrow. The myeloid to erythroid ratio is also lesser, right? So it's a peripheral smear. In this particular peripheral smear, you can see neutrophilic leukocytosis. The neutrophil count is it's looks to be raised. Apart from that, you can also see a shift to the left. You can see multiple precursors, like you mentioned, of myeloid origin, right? And usually in the peripheral smear, you'll get a myelocyte bulge. Okay, like you said, you can also see basophils and eosinophils as well. And there doesn't seem to be a increase in blasts. So based on this, you can see that it's a chronic myeloid. Based on the symptoms as well as the peripheral smear, you can see it's a possible chronic myeloid leukemia, possibly in CP, although you have to confirm later. So okay, so what are the how will you further work up this case?
First we'll do CBC and peripheral smear, and then we'll do bone marrow for cytogenetics, because from peripheral blood we won't be able to do fish cytogenetics because blast percentage may be low. So, and also to differentiate between chronic phase and blast phase, we'll do bone marrow aspiration and biopsy, and we'll do quantitative RT-PCR and fish cytogenetics, and then
Yeah. So I'll just refine your answer. So here, to stage and diagnose the disease further, you've done your CBC bio, you've done your peripheral smear. Then next you'll do a bone marrow aspiration implant biopsy. From the bone marrow, you'll send a additional cytogenetics, right? Bone marrow to confirm the phase once again, and also to done conventional cytogenetics, including looking for additional cytogenetics. Then you need to look for BCR ABL transcript. So either conventional cytogenetics you take from the bone marrow because you need to look at metaphases, which you'll get from the bone marrow only. Okay. But for the BCR ABL transcript, you can do it from the marrow or the peripheral blood. You do that with both fish and PCR. Okay. We do not, the advantage of fish is you can find out atypical transcripts. The type of transcript you'll know via PCR. On baseline, you always do a qualitative PCR. Okay. Always remember this. You always do a qualitative PCR. Okay. So can you tell me, what are the features of the SOCAL and ELTS risk scoring? What are the components?
Yeah, SOCAL score component will be platelet count, age, spleen size, and basophil percentage.
Yeah. Okay.
Blast percentage.
Yeah. So what is the difference? Although they are the same components, what is the difference between SOCAL and ELTS?
Not sure, boss.
Yeah, so SoCal is for the what do you call it? The pre-TK era, right? So interferon era, and ELTS is for the TK era. In ELTS score, because TKIs can be easily given in elderly patients as well. So there you can the weightage for age in influencing the prognosis decreases. So weightage of age is decreased in ELTS score, which is used in the TK era. Okay. Now, how will you decide for treatment in this particular patient? What
Well,
are the features, components you look at?
uh, well, first start with TKI if it is in chronic phase, and
So before starting deciding which TK, what will you look at? Okay, so I'll just quickly mention that. Number one, you look at whether the patient requires a treatment-free remission. So patients who are planning for pregnancy or young patients who do not want to take long-term TK, there you can consider giving a second generation TK for to achieve faster, deeper responses, right? Now you can look at this ELTS score. The ELTS score is in high risk. There also you can give a second generation TK. Whereas if it's low or intermediate, there you can give a first generation TK. Then the third thing is you look at the comorbidities and the other afflictions of the patient to decide the TK, because each TK has a different toxicity profile. So these are the three things you look at. Now, initially in the first year, how will you monitor treatment? What do you use to monitor treatment, and how frequently do you monitor treatment in the first year?
in the first year, we'll see the BCR-ABL percentage, that is molecular for molecular response, to see in three monthly and at 3 months, and then at 6 months. And BCR-ABL at 3 months should be less than 1%, and at 6
Okay,
months.
I'll correct you there. Okay. So you're right, 3 months, 6 months, and 1 year. So that's where you'll monitor in the first year. You should always do a count. You should always do clinical examination to look at the status of splenomegaly. Okay, at all three, third, sixth, and 1 year. Now, you once you've done that, so at 3 months, treatment failure is considered to be lack of complete hematological response. Complete hematological responses, platelet,
less than
4.5 lakhs total count.
WBC less than 10,000.
Should be less than
No
10,000.
spleen and no blast.
Yeah, no blast in the peripheral smear, right? And no circulating, precursor cells as well in the peripheral smear. Okay, so that is a complete hematological response. You need that by 3 months. At 6 months, it should be less than 10% at least. If it's greater than 10%, then it's considered treatment failure. At 1 year, you should have at least less than 1%. Okay, so that is the criteria. How frequently you'll monitor? You'll use a quantitative PCR along with clinical examination and CBC as well. And you need to attain CHR at least by 3 months. At 6 months, you need to at least attain less than 10%. And at 1 year, you need to at least attain less than 1%. Okay. So what are the criteria? What is treatment-free remission? What are the criteria to give treatment-free remission?
The patient should be more than 18 years, and the duration of TKI should be more than 3 years, and patient able to monitor the quantitative PCR testing every month, and
Yeah, so you have mentioned some of the points. So
and who achieved MR4 or MR4.5.
yeah, so you should mention it completely. So just everyone just study this exact thing. They'll definitely ask DFR in the exam. The patient should have been diagnosed in CML-CP, right? Upfront. It should be a typical transcript. So it should be a P210 transcript, right? It should not be an atypical transcript. Then the patient should be, willing to undergo regular monitoring. Then you should have access to a quantitative PCR testing that has fast results, right? And that is highly sensitive. Then you should, you need to have used first generation at least for 5 years, second generation at least for 4 years, and you need to have attained a deep molecular response. So if it's MR4, it should be for 3 years. If it's MR4.5, it should be at least for 2 years, right? So that period as well as the duration of deep molecular response, both those are important. And you should do monitoring how frequently?
Every month. We should do quantitative RT-PCR.
Yeah, so every month for 6 months, then 2 monthly for the next 6 months, then every 3 monthly thereafter. Okay. If you have loss of MMR, only if you have loss of MMR. So even if deep molecular response is lost, you do not continue TFR. But if you have loss of MMR, then you restart the same TK, and most of the patients will once again attain deep molecular response. Okay. So what is on PCR? What is considered to be complete cytogenetic response?
If there is no pH positive
What is the percentage on PCR?
0 to 35% is
So complete cytogenetic response on PCR is less than 1%. Okay.
less than 1.
And major molecular responses? Less than 0.1%. Okay.
Mm.
Okay. So I think all of you just go back and watch the splenomegaly video posted on YouTube. Everything is covered there. You study that. That is more than enough. Okay. So that is CML. They'll definitely keep this because CML is one of those conditions where the patient has a normal lifespan. So it'll definitely be there for the practical exams, either as a short case or in your grand viva rounds, right? So just look at that video that I posted on YouTube. That has all the details you need.
Okay.
Right. Okay. Now we'll go back to Dr. Vaishak. This is a 23-year-old male with neck swelling of 5 months with unexplained fever and weight loss. Histopathology of the neck swelling shows the following. What could this be? Can you describe this? And Dr. Vaishak? Yeah, okay. We're not able to get through. So, Dr. Raja, can you tell me what this is?
There's a histopath slide of the lymph node showing a owl-eyed appearance, nucleus, bilobe nucleus, likely a Reed-Steinberg cell consistent with Hodgkin's lymphoma.
Okay, good. Yeah, so, a classic Hodgkin's lymphoma appearance. So what you see here is you'll see a large multinucleate. So this first of all, this is a biopsy of the neck swelling. It shows a large multinucleated cell, right? And it's got a bilobed nucleus with surrounding halo, giving an owl's eye appearance, right? And if you look at the nucleoli, it is eosinophilic nucleoli that is present in the center. And you've got around the multinuclear giant cell or the Reed-Sternberg cell, you've got inflammatory background as well, right? So that gives idea for Hodgkin's disease. Okay, what is the IHC here that you'll tend to see?
In classical Hodgkin's lymphoma, it will be CD15 and 30 positivity, and there will be B cell expression, but they can be absent or low. In atypical, means non-classical, it will be CD20 and 45 positive.
Yeah, so NLPHL, you will get B cell markers will be positive, right? CD79A, CD20, PAX5, etc. will be positive in NLPHL. Okay, Hodgkin's, you'll get CD30 and CD15 positive. Okay, now there's early and advanced stage in Hodgkin's, right? How will you divide the early stage into favorable and unfavorable? Can you name two risk scores?
There is a AORTC risk scoring, and there is by the German group GHSG scoring, in which if there are B symptoms, then we have to see ESR. If B symptoms are there, ESR should be less than 30, qualifies for unfavorable, favorable. If no B symptoms, ESR should be more than equal to 50. MMR should be more than 0.33, and there should be more than 3 lymph nodal areas involvement. Yes.
Right. So so you should first of all you should mention which type you're saying, right? So GHSG and EORTC are there. So you look at MMR, the nodal group areas. You look at presence of B symptoms, ESR, etc. So based on the EORTC and GHSG are different. Those two we can remember. You can go back to the lymphoma video. So all of that is given there. Okay. So based on that, you divide into favorable and unfavorable. Okay. So what is the treatment for favorable early Hodgkin's disease?
So in favorable early Hodgkin disease, I will give multi-agent chemotherapy in the form of ABVD 2 cycles. Then I will undergo an interim PET CT, and I will decide the further treatment based on the PET CT report.
It is in CMR.
After PET CT in stage 1 or in early stage, if it's a CR, I can go with consolidative RT at a dose of 20 gray plus 1 ABVD, or I can 20 gray plus 1 ABVD, or I can also give 2 ABVD more cycles.
Okay, so I'll tell you the difference here. In early, it's divided into favorable and unfavorable. Okay, if it is favorable, you can give 2 cycles of ABVD, do a PET If it's in CMR, you can just give 20 gray IFRT, that is enough. Now, if it is unfavorable, you give 2 cycles of ABVD, and if it's PET CMR, then you give 2 more cycles of ABVD and consolidate IFRT 30 gray. Okay. Another option in early unfavorable is 2 cycles of ABVD. If in PET CMR, you can omit bleomycin and give 4 cycles of AVD. So there you can consider omitting RT as well. Okay, so these are the two most commonly. I hope you got the difference between early favorable and early unfavorable. Now, advanced what is the treatment you would prefer?
In advance, we have two approaches. We have the Kairos, we have the Chronos. Means we can go with the intensified regimen. Then based on interim PET, we can de-intensify, or we can go ahead with the ABVD regimen, and based on PET, we can intensify.
Okay, so what is the standard of care right now?
So we give 4 cycles of ABVD and then do an interim PET CT. No, right now, standard of care as per based on the SOG 1826 trial, we give, there is no PET approach based treatment. We give 6 cycles of nivolumab, ABVD, or we can also give
brentuximab. So AVD, right? You omit bleomycin. So I'll
AVD.
just say the answer. So current standard of care is nivolumab plus AVD that has shown a PFS benefit over earlier BV plus AVD. Okay. So there it's not a PET mediated approach. You give nivo AVD 6 cycles, right? And then evaluate with PET. So that is standard of care. Another option that was present earlier before nivo AVD was brentuximab vedotin and AVD 6 cycles. There also it is not a PET adapted approach. If you're not another option that is based on HT21 trial is BRCAD. Okay, so you'll give BRCAD regimen which also contains brentuximab vedotin, and you'll give 2 cycles. If it is PET is in CMR, you give 2 more cycles. If PET is not in CMR, you give 4 cycles. Okay, and earlier we used to give ABVD into 2 cycles. If PET is in CMR, based on the RATHL trial, you can omit bleomycin and give ABVD. Okay, and if PET is not in CMR, you escalate to escalated BRCOP. Okay. So that is the approach of advanced. Nivo AVD, brentuximab AVD, BRCAD, these are the 3 ones that are used. Earlier, we used to give ABVD and escalate or de-escalate based on the presence of CMR, based on the RATHL trial. Okay, so that's the approaches to advanced. Can you tell me the dual scoring?
Dual scoring is a PET-based scoring which sees the avidity based on the liver and mediastinum. So one is dual score 1 is the background activities less than mediastinum. Score 2 is background activities more than mediastinum but less than liver. 3 is background activity more than liver and it is moderately enlarged. And then 4 is markedly enlarged.
Yeah, okay. So I'll just
I just flipped.
Yeah. So dual score 1 is if there is no uptake. Okay.
No uptake, then 2, yeah.
2 is less than mediastinum. And 3 is greater than mediastinum but less than liver. And 4 and 5 is
moderately more than liver, 5 is markedly.
Yeah.
And X is new uptake.
And 1 to 3 is considered to be CMR. Okay. Can you tell me the difference between IFRT, ISRT, and INRT?
In involved field radiation, we take the entire nodal station, the entire chain, and in involved site, we include the particular level of the lymph node radiation is done.
Okay, so for level 2 cervical node, okay, how will you give IFRT?
So I'll include the entire cervical chain, level 1 also and level 3 also.
Yeah, so you'll include the entire cervical chain and supraclavicular fossa as well. Okay, so that's involved field RT. Now ISRT, like you said, if it's
only
level 2, yeah, if you have a level 2 node, you treat only level 2, right? And INRT is
only that particular lymph node which was positive based on the PET CT will radiate that.
Yeah, so based on the pre and post treatment chemotherapy imaging, you'll take that into account and treat only the node that is involved, right? So that is the most precise form of radiation we can give. So that is also asked. IFRT, ISRT, INRT. Just go watch the lymphoma video. It's there. The differences. I've mentioned it in detail. Okay. Okay, good. Now let's go to the next question. I'll go with Dr. Sriram. Okay, so this is 68-year-old lady presents with fatigue and back pain. Lab workup shows anemia with hypercalcemia, and bone marrow evaluation shows the following. What can you see here?
Yes, sir. There are actually eccentrically placed cells showing eccentrically placed nuclei, probably like plasma cells, with the cartwheel appearance in the right side. So possibly multiple myeloma.
Yeah, so you can see these large cells with oval and abundant cytoplasm with an eccentrically placed nuclei with with perinuclear HOF. You can see that light area around the nucleus, right? That's called a perinuclear HOF. So that could point towards a myeloma, right? Um,
Myeloma.
okay, now can you tell me the criteria for diagnosis of a multiple myeloma?
Yes, sir. Basically, sir, it's the means earlier it was the crab criteria. Now it is the slim crab criteria. That is the serum monoclonal light chain elevation, along with this means hypercalcemia, renal involvement means bone lesions and anemia. And one more is
Okay, so I'll just summarize that. So
yeah.
to diagnose a case of myeloma, this always works. Remember this. You have the major criteria, and so we use the slim crab criteria, but to use it practically, I'll tell you how it is used. You have major and minor criteria. Okay, so you should meet one major and one minor. So what are the major criteria? On bone marrow biopsy, you should have greater than 10% plasma cells with light chain restriction, or you should have a biopsy proven plasmacytoma. So those are the two major criteria. It should meet one of them. Then you have the minor criteria. You should have at least one minor criteria. So what are the minor criteria? Your traditional crab features. So calcium that is greater than 11, hemoglobin that is less than 10, serum creatinine that's greater than 2, or the presence of any lytic bone lesion. Okay. Or if you have plasma cells in the marrow that is greater than 60 percentage, or presence of kappa lambda light chain ratio of greater than 100 is there, or if there is any MRI lesion, regardless of whether it's lytic or not, that is greater than 5 millimeter. So those are all the minor criteria. So if you have one major and one minor, diagnosis of myeloma is made. So I hope you got that. You can go back and watch this video on YouTube and know how to make a diagnosis. So you need one major and one minor. Okay. How do you diagnose plasma cell leukemia?
Plasma cell leukemia, sir, like usually it is like more than in peripheral smear itself, there will be more than 5% blast.
Yeah, so you'll see greater than 5% plasma cells in the peripheral smear. Okay, that gives a diagnosis of plasma cell leukemia. Okay, what are the high-risk cytogenetic features of in myeloma?
Yes, sir. That is one is deletion 17, then P53, then
Okay, I'll
exactly
quickly say that. Translocation 414, translocation 1416,
14,
translocation
16.
1420, deletion 17p, gain 1q, and deletion 1p. Okay. Okay, now can you tell me the ISS staging for myeloma?
ISSS, sir, means serum beta 2 microglobulin and serum beta 2 microglobulin and serum albumin both are seen. Means albumin more than 3.5. Beta means ISS 1 is albumin more than 3.5. Beta 2 microglobulin. Beta 2 microglobulin more than 3.5 and albumin less than 3.5.
I think you. I'll just tell you. I'll just step in there quickly. Albumin is greater than 3.5 and beta 2 microglobulin is less than 3.5 in stage 1. There is no high-risk cytogenic abnormalities and normal LDH. Okay. Now stage 2 is that which does not fit into stage 1 or stage 3. Stage 3 is beta 2 microglobulin greater than 5.5 or high-risk cytogenetics in ISS, revised ISS they have mentioned translocation 414, translocation 1416, and deletion 17p. Only these three they mentioned. Or raised LDH. That is RISS stage 3. Okay. Now, in a case of myeloma,
Yes,
that is transplant eligible, right? How will you treat the patient? A fit patient, less than 65 years of age,
fit
no comorbidities.
patients, I will go ahead with the daratumab plus means VRD regimen. Then after that means
How many
post
cycles?
induction, usually 4 cycles, 4 cycles. Then later I'll go ahead with the means autologous transplant, followed by which I'll give a maintenance.
With?
Maintenance with means this if it is a high risk patient, that again depends on the risk, sir. If it is a high risk patient, then we have to give sir, exactly I'm not able to
I'll tell you exactly how the treatment is. Everyone listen up. So In myeloma, the current standard of care based on the Perseus trial and other trials is daratumumab plus VRD. VRD is Velcade, which is bortezomib. R is Revlimid, which is lenalidomide, and D is dexamethasone. Okay, so Dara VRD, regardless of risk, is the standard of care. In the Indian setup, where we cannot preserve the stem cells in between, we give 6 cycles of Dara VRD, right? Following that, we look at whether the patient has attained a very good partial response or a complete response. If they have attained a very good partial response or complete response, then you take the patient up for autologous transplant if they're transplant eligible. That is, if they're young with no comorbidities, right? So autologous transplant, you give 200 milligram per meter square of melphalan as conditioning regimen to autologous transplant. And following autologous transplant, based on the risk, you give either bortezomib plus lenalidomide maintenance if it is high risk, and only lenalidomide maintenance, single agent maintenance, especially usually with lenalidomide if it is low risk. Okay,
Standard.
so that is how you treat the patient. Now, if they're not affording for DARA, you give VRD into 6 cycles transplant and give maintenance, dual maintenance if high risk, or single maintenance with lenalidomide if low risk. Okay, I hope you all understood that. What are the causes of increased serum creatinine in myeloma?
One is the deposition of the means light chain in the like kidney. That
Okay,
is
so
one.
that is just one
Uh,
one cause. Keep going.
that is one. Then also amyloidosis can be a accompanying factor
Okay.
with the myeloma. That can be one factor.
Hypercalcemia.
Hypercalcemia itself can cause a renal failure.
Okay. Okay. So yeah. So light chain nephropathy, light chain cast nephropathy, hypercalcemia. If you have amyloidosis, amyloid deposition, if the patient has infections, which is very common in myeloma, right? It can cause sepsis and renal failure. Various drugs like lenalidomide, zoledronate, which is given for bone strength, and NSAIDs, which might be prescribed by non-oncologists for pain, can also cause. Also, dehydration can also cause. This. So those are the various factors that cause hypercalcemia in myeloma. Okay, how will you match? Suppose a patient comes to you diagnosed with myeloma, serum creatinine is 8.8, light chain you have looked, it is 8,000, right? Value is
Yes.
8,000. Okay, kappa light chain
Yes.
value is 8,000, ratio is around 300. How will you manage this patient?
So first I'll admit the patient, sir. Then I'll look at means I'll do a means ultrasound initially. The means to rule out other causes means what are the cause of
So we have
the.
already diagnosed as a case of
In that
myeloma.
case, we'll give sir cyborg will be preferred
Okay.
regimen if you have to start chemo.
Okay,
We'll
so just
start with
cyborg.
the no sir. Initially we'll start with the means dexamethasone as a pulse dose. Then it will slowly escalate with
Okay, so the answer I'm looking for is first you'll admit the patient, right? You'll start the patient on hydration and anti-TLS measures, right? And others of the kidney failure can worsen. Then you'll send a nephrology consultation for plex, right? To remove the light chain load, and also with added, hemodialysis if required, right? If there's any indication for the same. Also, you'll start the patient on Cybord regimen, right? You can't give lenalidomide here with such a raised serum creatinine, so you'll give Cybord regimen, and along with that as well. So Plex, hemodialysis, hydration, anti-TLS, and Cybord regimen. All these things should be mentioned, right? In a case of light chain cast nephropathy with high light chains and deranged kidney functions. Okay. Okay. Let's move on to the next question. Okay. Dr. Salahuddin.
Yes, sir.
Yeah. So you have a 59-year-old male presents with history of LRTI. Total count is less than 1 lakh. Flow cytometry is positive for CD33, CD117, and MPO positive. Okay. This is the peripheral smear. What do you see here?
Sir, we in the peripheral smear we see there is or rods are seen in large cell in this in the immature nucleus, and in the other peripheral smear we see MPO positive cells with dark staining.
Yeah. So you see these large cells, right, with high nuclear cytoplasm ratio, with prominent nucleoli. You also see cytoplasmic granules, and which some of which have clumped together to form OR rods, right? So what could
Yes,
this
sir.
point towards?
Sir, this could point towards diagnosis of AML.
Yeah, AML. So, okay. So, what are the stains used in AML?
Yes, sir. We are using generally MPO and as well as PAS and Sudan Black
Okay, so PASS is used for ALL. In AML, use
also.
MPO, like you said, Sudan Black as well, and neuron-specific analysis. Okay, NSE. Okay, so coming to the risk stratification, can you tell me three mutations of favorable risk, three mutations of intermediate risk, and three mutations of high risk?
Favorable risk mutations are generally translocation in 16 translocation 1616. Um, then there is
Okay,
sir.
I'll quickly mention it. You're right.
Mhm.
Favorable is translocation 1616, inversion 16, translocation 821, right? And biallelic in-frame SEPA mutation, CEBPA. Okay, intermediate risk is presence of FLT3 mutation or presence of FLT3 mutation with an NPM1 mutation or presence of translocation 911, or if it does not fit into, if it doesn't have any mutation that fits into intermediate or high risk or favorable risk, all that comes under intermediate. Then coming to high risk, you have many ones like TP53 mutation, or if it's secondary AML associated with deletion 7q 5q, or if you have 11q23 changes, or if you have other mutations such as ASXL1, SRSF2, etc. Okay. So just know a few mutations they'll ask you, because the treatment depends on the mutation. So how will you treat a favorable risk AML?
Sir, we'll first see if the patient is fit or unfit.
Okay.
And then, if the patient is fit, we will start with an induction regimen in which we will give the patient a 7+3 regimen, which consists of 7 days continuous infusion of cytarabine at a dose of 100 to 200 mg per meter square. Along with that, we will have give 3 days of we'll give 3 days of doxorubicin, which
Donorubicin.
donorubicin at the rate of 60 mg per meter square. After that, we will evaluate the patient on day 14 for the response. So if the patient has adequate response or inadequate,
What is adequate response?
Sir, adequate response will be the patient should have less than 5% blasts in the bone marrow. Along with that, the absolute neutrophil count should be more than 1,000, as well as the total platelet count should be more than 1 lakh.
Okay. And also with that, do we do something else?
Sir, in the peripheral smear also, CBC also we'll see, sir.
So we do MRD also from the marrow. Okay, by
MRD.
flow cytometry, we also do MRD. MRD should ideally be less than 0.1%. So if all this criteria is met, MRD negative and in morphological remission, then what do you do?
Then, sir, we'll consolidate the therapy. We will consolidate the treatment. Generally, we have again we'll see the patient is falling into which is it favorable risk,
If it is favorable
intermediate
risk.
risk. If it is a favorable risk, then the patient we can give maintenance. We can consolidate that treatment with with the
High dose
therapy.
Arasi, right? High dose
High
Arasi.
dose. Yes, sir.
High dose Arasi usually give 2 to 3 grams per meter square, day 1, 3, and 5, and you give 3 cycles of that. That's how you consolidate in favorable risk, that is in morphological remission and MRD negative post induction. Okay. When you come to if favorable risk is in MRD positive, or if it is a case of intermediate risk or adverse risk, you give induction and consolidate with an allogenic transplant. Okay. So intermediate and high risk or favorable risk, that is MRD positive, but in morphological remission, you consolidate with a transplant. Okay. So I hope you got the treatment of various risks. Now, coming to if the patient is not fit for intensive treatment, what do we prefer nowadays?
Sir, if the patient is not fit for intensive regimen, then we have other options, which constitutes of giving the patient hypomethylating agents such as azacitidine or decitabine. Along with that, we can add agents which are such as BCL2 inhibitors like venetoclax.
Okay, what's the
Along
dose
with
of
that,
azacitidine and venetoclax that we give usually in India?
Venetoclax is, sir, ramp up dosing we have to do. We start with 20 mg dose, And generally, practically, we are giving 100 mg per day in India, but we have the dose can go up to 400 mg for venetoclax. For azacitidine, sir, I think it's 100 mg. I can't recall, sir.
Yeah. So,
Azacitidine, right?
so you got the concept right. Azacitidine is 75 milligram per meter square, day 1 to 7, given IV. Venetoclax is given orally. It is a BCL2 inhibitor. Usually we do a ramp up of the dose. That is on day 1 we give 50, day 2 100, day 3 200, and day 4 we give 400 mg and then continue on the same dose. In India, what we tend to do in most centers is we give 100 mg. We combine that with voriconazole, which is a
Voriconazole or
CYP3A4
posaconazole.
inhibitor. Okay, so it decreases
Yes,
the metabolism of venetoclax. So we can give a dose of 100 milligram only. Okay, so we can
yes.
save the patient's funds like that. Okay. Okay, now we'll move on to the next question. Okay, a 34-year-old presents with cough dyspnea of rapid onset, and biopsy is done of the lung mets that are seen, and it leads to intrapulmonary hemorrhage, and HP shows the following. Okay, Dr. Praneeth, can you tell me what we're seeing here?
Sir, we can see histopathology showing reddish.
Yeah, this is a slightly tough one. If you're not able to, it's okay. I'll just tell you. Okay, they can keep this
Okay.
because this is a curable malignancy. Okay.
Okay.
So what they tend to, they kept this for my exam. So what you see here is you see stark, it's, you can see areas of hemorrhage are seen all over. Okay. So
Yes.
areas of hemorrhage, and you also see, you see these dark strands that are seen. You can see my cursor. These dark strands are actually syncytial trophoblasts. So they're multinucleated, as you can see here, darkly stained nucleus. And you have also cytotrophoblasts that you see here with my cursor. Okay. So if you see this picture, automatically a diagnosis of choriocarcinoma should come to your mind. Okay.
Okay.
So choriocarcinoma, can you tell me how do you post a molar pregnancy, either a complete or partial hydatidform mole? How do you monitor the what are the criteria to be met for it to be a gestational trophoblastic neoplasm? So post a molar pregnancy, either complete hydatidform mole or partial hydatidform mole, what criteria need to be met for it to be a gestational trophoblastic neoplasm? Choriocarcinoma is one of the types of GTN. So what
Yes.
criteria to diagnose it as a GTN?
Sir, patient should have either flattened beta HCG or rise in beta HCG, persistent rise in beta HCG, and next patient should have
Yeah, so you need to be specific. Plateau and beta HCG, on 4 tests done on day 7, 1, 7, 14, and 21, right?
yes,
Or
sir.
an increase in greater than 10% seen on 3 tests done on day 1, 7, or 14. Increase in greater than 10%. Then what are the other features? Histological, if you have a histology of choriocarcinoma, or if you have presence of metastatic disease. So of any of one of these 4 are met, you take it as a GTN. Okay, while monitoring post-molar pregnancy. Okay, now coming to the next question. What are the WHO risk criteria to see whether it is a low risk or high risk GTN?
Sir, we have 7 to 8 parameters where we'll see first what is the gestation. Is it a molar pregnancy? Whether it is a abortion or is a term pregnancy? There we have 7 parameters, sir. Like gestation,
Yeah,
you
just
should
tell me
see
the
for.
parameters. That's enough.
So what is the gestation prior treatment, whether one drug or 2 drugs, number of sites of meds, size of meds, and next size of meds, site of meds, gestation, pre-treatment, time from diagnosis, index pregnancy, time from index
Yeah, so I'll
pregnancy.
just say it in order. Okay, so just study this in order. Age in years, right? Antecedent pregnancy, interval from the last molar pregnancy, uh, interval from the last pregnancy, pre-treatment beta HCG, then the largest tumor diameter, then the site of the Mets, number of Mets, and prior failed chemotherapy agents. Okay, so all 8 are there. You should look at the specific. This is one site you should remember because it's curative,
Yes.
right? So, how do you, what is the cutoff between low risk and high risk?
Sir, up to 7 it is, below 7 it is low risk, above 7 it is high risk, and above
Yeah.
13 it is very high risk.
Yeah. So 7 and more is high risk, below 7 is low risk. How do you treat low risk?
Sir, low risk will give methotrexate, sir. Methotrexate, we can give methotrexate or actinomycin D, but mostly we prefer methotrexate,
What is the
giving
dosage?
it. Methotrexate dose, it is, sir, we have weekly also, where
You
we'll
should
give
the
alternate
standard
day
standard
1,
one that is
day
given.
3, and day 5.
Okay.
I will give on day 1, day 3, and day 5, whereas in
And
day
7.
2, day 4, and day 8, we'll rescue with leucovorin.
Yeah, so I'll just summarize it for you. Okay, methotrexate is given at a dose of either capped at 50 milligram, or you give it at 1 mg per kg, and you give that on day 1, 3, 5, and 7. You rescue leucorin, you give 15 to 20 mg, and you give that on day 2, 4, 6, and 8. That is the standard. Okay, if it fails on methotrexate, then you can consider giving datomycin. You do it till beta HCG is normal, and following that, you give 3 more cycles to consolidate once it's normalized. Okay. High risk, how will you treat?
Sir, high risk, if it is high risk, we'll proceed with imaco regimen, sir.
What are the components of imaco regimen?
Yeah, in imaco regimen, we have etoposide, actinomycin D, methotrexate, and cyclophosphamide,
And OH
vincristine.
for vincristine, right?
Vincristine, sir.
Okay. So you give once again till the beta HCG normalizes, and you give 3 more cycles to consolidate once it's normalized. Okay.
Yes, sir.
How will you treat a patient who's highly symptomatic, or has got hemorrhage, or has ultra high risk?
Sir, initially we should treat with pre-phase chemotherapy, because there would be high risk of.
What is prephase?
Sir, we'll give etoposide with etoposide plus cisplatin, sir.
Yeah. So etoposide, you will give 100
100
milligram per
mg.
meter square, day 1 to 3, and you'll give what do you call cisplatin, 20 milligram per meter square, day 1 to 3. You can repeat that weekly till the patient is symptomatically better, right?
Yes, sir.
Otherwise, there's a high chance for hemorrhage, or if the patient has got extensive disease, or even if the score is greater than 12 or more, there's a high chance for hemorrhage and other complications. So you give a prephase first. Okay.
Yes, sir.
I hope you all got that. This can be asked. This has been asked before in DNB as well as in various DM exams as well.
Okay.
Okay, let's move on to the next thing. Dr. Vaishak, are you there? Okay. If not there, we'll go to Dr. Poonam. Okay. Can you tell me? Can you describe what we see here? This is a case of a 64-year-old who presents with a breast lump with a history of 4 months, right? With nipple inversion and nipple discharge, and the mammogram has been taken. So what do you see here?
This is a medial lateral oblique view of mammogram showing calcifications and lesion in the upper quadrant of the breast, showing microcalcification with his spicules. Case of CA breast, and also
Okay.
yes.
I'll just step in over there. So when you get you'll definitely get a mammogram.
Yes.
Okay. Number one, you should say this is a mammogram of the left breast. It's mentioned above. Craniocaudal views there, and mediolateral oblique views are there. Okay. Now, what you should know here is that first you should localize the tumor where it is located at. Okay. So localize by first looking at the mediolateral view. If it is located above, as you can see here, it is in the one of the upper quadrants.
Okay.
In craniocaudal view, if it is located above, it is lateral. If it is below, it is medial. Okay, so this is located in, above. So it is, so based on medial lateral, it is in the upper quadrants, and based on craniocaudal, since it's located above, in the craniocaudal view, it is outer. Okay, so it is located in the upper outer quadrant. Next, you define the lesion. So there you see, here you see multiple lesions, predominantly large one, which is hyperdense compared to the surrounding breast. It's got a spiculated margin, and there is distortion of the normal trabecular lines in the breast. That is architectural distortion is there. There is also associated microcalcification, And if you look at the mediolateral view, there's presence of axillary lymph node as well with loss of fatty hilum, as you can see here. Okay, so all these point towards a suspicion for malignancy of the breast. What is the BIRAT score?
BIRAT's score 0. Assessment, incomplete assessment is there, and 1 is negative, 2 is benign findings, and 3 is probably benign but need a short follow-up interval, like every 6 months, and 4 is 4 is
What is the risk of malignancy in 3?
3. It is was 2%.
Less than 2%. Okay.
Less than 2%.
Yeah, continue.
And for suspicion of malignancy, we need to consider biopsy in BIRATS 4. And for the risk of malignancy in 4 is 10 for A, 4B, 4C. 4A is 10%, then 4B is 10 to 50, and 50 to 95%. And 5 is highly suggestive of malignancy, and proven, 6 is proven malignancy.
Yeah, okay. So that's BIRAT score. You should say just like that. Okay. What are the type of breast malignancies, breast cancer where you'll get no mass? So lobular invasive lobular carcinoma and inflammatory breast cancer. Okay.
Okay.
Okay. So can you tell me, so in screening you have only MLO and CC views. In diagnostic you have additional views. Can you name some few additional views in mammogram?
Yes, boss. It is axillary views and
okay, so basically you have spot view, spot compression, right? You have valley view, then you have what you call mediolateral view or lateromedial view, right? And then you have magnification views. So just mention 3 of them. Exam will be happy. Okay. When you're following up with mammogram post-treatment, how often do you do a mammogram?
Post-treatment, yearly mammogram is needed.
Okay. So yearly, yeah. Post-treatment, you do yearly mammogram, right?
Yes.
With physical examination and what do you call it? Yeah, history and physical examination. Okay, good. Okay, now we'll move on to the next question. This is for yeah, we'll give this to Dr. Karamveer. Yeah, okay. So a 32-year-old male being treated for testicular malignancy developed dyspnea on exertion and came to the casualty. HRCT thorax shows the following.
So this is HRCT showing parenchymal view, and in this bilateral basal area showing organized consolidating path, GGOs, likely bleomycin inducer.
Yeah, so you're right. The HRCT thorax, this is in the lung window, and here you can see septal thickening. You can see this thickening over here, right? So you have diffuse bilateral septal thickening, and you also have ground glassing along with formation of few nodules. Based on the history of testicular malignancy on treatment, it's looking like a bleomycin induced pneumonitis, right? What is the reason for bleomycin causing pneumonitis?
So due to deficiency of bleomycin hydroxylase in lung tissue.
Yeah. Okay. What are the absolute and relative contraindications for bleomycin?
Sir, absolute contraindication is age. So usually we don't give in age more than 60 years.
Okay, so that comes under relative. Okay, so I'll just quickly mention. I've mentioned it in the testicular malignancy video. Go check that out. So absolute is if the DLCO is less than 30%. Now coming to relative, it is if the DLCO is between 30 to 60%. If the patient has age greater than 40 years, if the patient has a smoking history, if the patient has history of previous lung RT, if the patient has other lung pathologies like COPD, right? If the patient has an impaired creat clearance, all these are relative contraindications. Okay, so absolute is only DLC less than 30. Relative are all the other ones that I mentioned. For this particular case, suppose the patient say has grade 2 bleotoxicity. How will you manage this patient?
We give supportive management. And steroid is one of the drug we used to treat, and so try to avoid oxygen, sir.
Okay, so you got the concept right. So usually if it is, we start off with dexamethasone 8 mg BD since the patient is symptomatic and has got pneumonitis, right? And we continue at that dose till the patient is symptomatically improved. Then we slowly taper over 4 to 6 weeks. Okay, so that is how you treat. And during this time, we try to avoid oxygen supplementation and we try to keep the FiO2 if absolutely needed below 30%. Okay, so that is how you manage it. Okay, this is also very commonly asked. Okay, so the next question goes to Dr. Raja. Dr. Raja? Yeah. Dr. Raja, are you there? Okay, we will then go to Dr. Chandana. Are you there? Okay.
So this is T1 weighted.
Okay, then we'll go to Dr. Sriram.
Yes. Was a 65-year-old male with headache for 6 months. So there is a MRI, which is a T1 image, T1 contrast image showing a means hyper intense lesion in the frontal lobe, which is crossing the midline and extending into the contralateral hemisphere. Probable diagnosis is a high grade glioma, possibly glioblastoma.
Yeah, so you're right. So here we can see that it is a T1 weighted image with contrast enhanced. You can see the vessels here. And here you see a lesion that is occupying both hemispheres. And you have contrast uptake. You have areas, cystic areas, along with necrosis, this darkened area in the center. And this classical butterfly glioma, right? That is looking like GBM, glioblastoma multiforme. Okay. So what is the diagnostic criteria based on the recent WHO of GBM?
Yes.
Can you tell me?
IDH negative CDK and 2A.
Which is like means diagnostic criteria for GBM. I'm not aware.
Yeah, so you should know this.
Exactly. Like
First of all, you should look at IDH status.
Yes.
If IDH is wild type, then you go for histological features. Okay, so first of all, IDH wild type and histological features of microvascular proliferation and necrosis. So once you have established those two things, then you look for presence of additional mutation. That could be a third promoter mutation or EGFR amplification or addition of chromosome 7 or deletion in chromosome 10. Okay, so IDH wild type with histological features of microvascular proliferation and necrosis combined with third promoter mutation or EGFR amplification or plus chromosome 7 or minus chromosome 10. Okay, so those two features need to be there in order to diagnose GBM as per the latest WHO criteria guidelines. So what is the STOOP protocol for treatment? Tell me the entire treatment protocol in GBM. What is the standard?
STOOP protocol was. Yes, so basically we'll go ahead with means surgery where we look for our aim is to get a gross total resection, but maximal safe resection is only possible in most cases. After which we'll go ahead with concurrent chemo radiation. The dose is actually 60 gray 30 fractions with the concurrent capecitabine. Then along with that we'll post RT we'll go ahead with the like adjuvant capecitabine. Concurrent dose actually 75 mg per
Adjuvant
meter.
capecitabine.
Means concurrent. Sorry. Concurrent
Yeah,
temozolomide.
see, when they ask you,
Temozolomide,
I'll just tell you, when they ask you a question, relax, think of the answer, then answer. Okay. It's
Yes,
okay
sir.
if you
Sorry,
take
sir.
a few seconds. Okay. So you start
Yes,
off with maximal safe resection, right? Once you've done maximal safe resection, then you give adjunct CTRT. CTRT consists of 60 grain 30 fractions with concurrent temozolomide, 75 milligram per meter square,
per meter
given
square.
day 1 to day 7. That is off
Yes,
days
sir. Yes.
as well you give.
You
Then
have to give
then you give adjuvant temozolomide.
adjuvant temozolomide. That is
150
given 5 months in a day. That dose is 150 to 200 mg per meter square.
Yeah, so
For
5 days
and we
every
cut
yeah,
month
5
for
days.
6 months.
Yeah, 5 days, not 5 months, 5 days. Okay. 5 days.
Yes, sir.
So
Yes, sir. 5 days in a month for total of 6 months.
yeah. So 150 to 200 milligram adjuvant, 5 days a month, every 28 days for 6 months. Okay. So my point again is think of the answer, think it through, then answer. Okay. Don't fumble up because I know you know the answer. It's very obvious, but the examiner should come across to the examiner as well, right? Okay. in STU protocol, what else can you add
Uh,
currently with as per the latest treatment?
protocol.
So you have tumor treatment fields. Okay. So in
Tumor
currently you have
treatment.
maximal safe resection, 60 and 35 radiation with temozolomide, adjuvant temozolomide for 6 months, right? Following that, you can also add tumor treatment fields, which is like a scalp electrode array that is kept, and that also increases the overall survival. Okay, so that is the full treatment protocol for GBM. What is pseudo progression? Where is it seen?
Pseudo progression, sir. Like initially, if we like treat the means initial after in the first follow up post treatment, sometimes there may be an increase in size of the tumor, which will be we cannot actually make out whether it is like means due to
Yeah, so
the
basically the answer is post RT. Radiation can induce necrotic changes, but it can appear as it can have contrast uptake and it might look like progression. Okay, so the radiation can induce pseudo progression post treatment. Can mimic pseudo progression. Yeah. So pseudo response is seen in which setting in GBM?
uh, pseudo responses. In when bevacizumab is given.
Yeah, so usually in second line setting, we give Versumab once a tumor is recovered. There it might look like the tumor has responded because it takes care of the peritumoral edema. So it looks like the tumor has responded when it's actually not responded, right?
Hmm.
Okay, so that is it. So GBM imaging, diagnostic criteria based on WHO, and STU protocol, you should know inside out. This is a very common, one of the most common malignant brain tumor. So you should know this inside out. Okay. Okay, moving on. So, Dr. Raja? Okay, he's not back. Okay, so 24-year-old boy presents with complaints of thigh pain associated with swelling. X-ray of the right femur shows the following. Okay, uh, Dr. Praneeth, can you tell me what you're seeing here?
Yes, sir. Sir, we can see an X-ray of a knee joint, both AP and lateral view, and in that we can make out a bony lesion at the distal end of the femur with a periosteal reaction, and there is a periosteal uplift, and there is spike-like projection coming out of the bone. Most likely a periosteal reaction, so a sunburst appearance is present, and there is a wide zone of transition can be less likely it is being seen, with some sclerotic and lytic lesions can also be visualized in it. Soft tissue, I would not make it that much,
Yeah,
sir.
okay. So you're right. You mentioned all the points. So ideally, this is not ideal X-ray. It should involve the entire bone along with the adjacent joints, both the adjacent joints. Okay. So here you can see basically you can see a lytic sclerotic lesion involving the distal end of the femur. Predominantly, the metaphysis is involved. There's a wide zone of transition, as you can see here, between normal and malignant bone. Um, there's also it also seems to be a periosteal uplifting that is seen. You can see that over here, and there's also spike-like projections, which is ossification along the vasculature, sunburst appearance. There's also something resembling a Codman's triangle as well, although that is not that prominent in this X-ray. And there seems to be no pathological fracture, or based on what we can see, ideally should be the whole bone. There's no skip mets. So all these points should come. Okay. So go back and watch this video. Mention all these points. Okay. As part of workup, so you're suspecting which malignancy?
So most commonly, I would suspect at this age group an osteosarcoma involving the distal end of the femur.
Yeah. So how will you work up this case?
Sir, first I would do an diagnostic and staging investigations. I would proceed with MRI of the local joint along with the adjacent joint, and along with CT chest as a staging workup, and then a biopsy which is along the lesion, along the planes of the lesion, which should be done by the primary surgeon who is going to operate, and it should not violate the compartments, and the incision should also be excised while patient is going for surgery.
So you should tattoo it, right?
Yes, sir.
Yeah. So you do, like you said, MRI, HRCT thorax, you do a biopsy, keeping all those guidelines that you mentioned in mind, and you can also do a bone scan, right? So all of that should be done, right? So local workup, MRI, metastatic workup, CT, local workup, MRI and biopsy, And metastatic workup, you'll do HRCT thorax and bone scan. Okay, what is the treatment protocol that you'll give for this patient?
Sir, we in our institute follow OGS 12 protocol, sir. Like
What are, just
IFOS.
tell me the drugs that are given.
Sir, initially for first 4 cycles, we'll give IFOS cisadria, cisplatin adriamycin for 2 cycles, followed by adriamycin and ifosfamide for 2 cycles, and then limb salvage surgery, followed by ifosfamide and cisplatin for further 4 more cycles, sir.
Okay, so you mentioned the OGS 12 protocol. Some places use IAP regimen, where you give 2 to 3 cycles of IAP, followed by ideally limb salvage surgery, followed by adjuvant chemotherapy, up to 6 cycles total, right? So what are you, OGS 12, MAP or IAP? Mention what is used in your institute. You can refer back to the sarcoma video for that. Okay, so what are the contraindications for limb salvage surgery?
Sir, contraindications would be neurovascular bundle involvement. If there is a pathological fracture, neurovascular bundle involvement.
So when they ask you this question, right, I've mentioned that in the earlier video. Number one, you should say absolute contraindications. So absolute contraindication is non-functional limb. Relative contraindications are pathological fracture, involvement of neurovascular bundle, if there is joint involvement, right? If there is a fungating lesion that cannot be salvaged, right? So all these are relative contraindications. Absolute one is non-functional limb. Okay.
Okay.
Okay. So I think that sums that up. Now, next. Okay. Dr. Poonam, can you tell me what you're seeing here?
This is colon cutoff sign.
Okay, so I'll just fill it in for you. This is actually a barium swallow scan, okay? And it's showing tapering and thinning of the barium passage, okay?
Okay.
So usually where do you see that?
In carcinoma esophagus.
Yeah, carcinoma esophagus. Okay, so they'll keep this actually. This is very commonly kept in the back exams. So to mention it is a barium swallow showing tapering of the esophagus, tapering of the dye intake, most probably due to growth, could be carcinoma esophagus. Okay, so what is the treatment for carcinoma cervical esophagus?
Cervical esophagus, it is as per magic trial surgery, CTRT.
Yeah, so I'll just say it. Cervical esophagus is from 15 to 20 centimeters and usually treat with radical CTRT, 70 grain, 35 fractions, okay, with concurrent chemotherapy because you cannot do surgery there. It'll cause high morbidity. For thoracic esophagus, it depends on the histology. So if you have squamous malignancy, the current standard of care is cross protocol. And if you have adeno histology, the current standard of care is ESOPEC protocol, that is perioperative float. Okay. Now, how do you give the cross protocol?
NACTRT followed by surgery in
The dose and the chemo regimen.
Yes, was weekly paclicarbo. Paclitaxel is a 50 mg per meter square with carboplatin of AOC2 every week. That with RT dose of 41.4 gray. And after 4 weeks, we'll do the surgery.
Okay, yeah. So 41.4 grain, 23 fractions with carbopacly, like you mentioned. Following that, you'll do surgery, right?
Yes.
Okay. And if the PCR is not attained, you can also give adjuvant nivolumab. Okay. So that is for squamous cell thoracic esophagus. Now for adenocarcinoma, we said a perioperative float. So 4 cycles of float before and after surgery. How will you administer float regimen?
Float regimen will it is a highly hematogenic, so we'll give for sapriptant 150 mg along with injection DEXA.
Is it highly hematogenic?
Yes, moderately hematogenic.
Yeah. So, okay, just mention the doses of the regimen. No need to mention the preoperative. We already discussed that in another video.
Docetaxel will be 85 mg per meter square.
50 milligram per meter square.
50 mg per meter square. Oxaliplatin will be 85 mg per meter square, and leucovorin 200 mg per meter square, and 5-FU will be 2600 mg per meter square over 24 hours.
Yeah, so you're right. Okay, so FLOT is given every 2 weekly, 4 cycles preoperatively and 4 cycles postoperatively, adenocarcinoma of CA esophagus, and the doses that you mentioned. Okay, there is no bolus 5-FU in FLOT. Okay, good. Let's move on to the next question. We'll give this one to is Dr. Karamveer there?
Yes, sir.
Yeah, so what do you see in this X-ray?
So this is just PA view of chest X-ray showing mediastinal widening, sir.
Yeah, so this is looking like some sort of a mediastinal mass, right? So what are the 3 most common causes of anti-mediastinal mass?
So one is thymoma, second is lymphoma,
Carcinoma, GCT.
GCT.
Oh yeah, so in that order. Okay, first is thymoma, second is lymphoma, third is GCT. So what lymphomas can present as a mediastinal mass commonly?
The primary mediastinal B-cell lymphoma, then sir lymphoblastic lymphoma, then sir T-cell lymphoma, T-cell.
Yeah, TALL, TLBL, T lymphoblastic lymphoma, PMBCL, and also like I mentioned earlier, nodular sclerosing Hodgkin's, right? Okay, good. Okay. So can you tell me the treatment of primary mediastinal seminoma and okay, first primary mediastinal seminoma.
Sir, it will be of good risk if you are not mentioning other things. So in good risk, we will use 3 cycle of BP or 4 cycle of EP. Sir, better to give 4 cycle of EP because there might be residual disease. So
okay, yeah. So yeah, you're right. Primary mediastinal seminoma usually comes under good risk. Okay, and in that case, you'll give 3 cycles of BEP. Okay, usually we give 3 cycles of BEP because usually it has a very good response. With chemotherapy itself, it's taken care of. Okay, now primary mediastinal non-seminomatous GCT, how will you treat that?
Sir, it will come under intermediate risk.
Poor risk.
Poor risk.
So non-seminomatous primary mediastinal, unlike seminoma, comes under poor risk. Okay, so how will you treat that?
4 cycle of BP, sir.
Do you give BEP in this setting?
Sir, better to give 4 cycle of VIP.
Yeah, VIP because you might have to go for a post-chemotherapy resection because the response rates with non-seminomatous mediastinal GCT is very poor actually. So in most cases you go for a resection. So if you give bleomycin, that might interfere with thoracic surgery, right? Okay, good. Now moving on, Dr. Sriram. Yeah, Dr. Sriram, are you there? Okay, Dr. Ronak, are you there?
Yes, sir. I'm here, sir.
Yeah, what can you see? What can you see over here?
Sir, we see mass compressing on the spinal cord around the cervical region. The mass is in the cervical vertebra around C7, C8, just before the or maybe T1. But this mass is compressing on the spinal cord and it will have focal neurological deficits in the anterior spinal cord, maybe.
Yeah, so this is a case of, see, just be very crisp when you're answering. Okay. This is a case of spinal cord compression, right?
Yes, sir.
Yeah, so this is a case of spinal cord compression. And so what are the most common causes of spinal cord compression?
The most common cause would be metastatic disease, and metastatic disease would be the most common cause.
Okay. Yeah. So what malignancies will you see? Spinal cord compression is what I'm trying to.
Prostate, CA breast in females, then any other maybe bone tumors also involving the vertebral column could cause this. Even multiple myeloma,
Okay, so just state in an order. Okay, most common cause for a spinal cord compression is right. Okay. Yeah. So most common cause for a spinal cord compression,
Would be CA breast
is it CA breast?
or CA prostate, sir, in males, and in females CA breast. CA lung also could have mets, but most common would be
See, so
metastatic.
most common cause is actually CA lung. Okay. CA
Okay.
lung is most common cause in 25% of cases, followed by CA prostate, followed by myeloma, followed by CA breast. Okay. So most commonly CA lung, then prostate cancer, then myeloma, then CA breast. Okay. So just remember that sequence. Now, how will you, work up this patient?
So first we would do MRI for this patient, and then we would immediately look at.
So MRI is already taken.
So we would want to do spinal decompression and see if it is pathological bone fracture or not pathological bone. Like if it is, if there's some pathological bone disease, then we would go for surgery directly for reduction. And otherwise, we would give in steroids and try to decompress local edema and focal neurological deficits and look at the response. And if the patient is still having focal neurological deficits, we would go for surgery invariably, sir.
Okay, so the treatment actually it depends on various factors. Okay, so first of all, when you get this case, you've done your MRI already. You need to know the pathology. So you need to take a biopsy from any biopsiable site. So before that, you do imaging. Okay, so uh, you do imaging, you do biopsy. Now, if the patient has any sort of spinal instability, or if the patient has any fragment that is impinging on the spinal cord, that patient needs emergency surgery. You refer for vertebroplasty. Okay. So you refer to the surgeon, the neurosurgeon. Now, if there's no spinal instability, or if the patient, does not require immediate surgery, or there's no fragment impinging on the spinal cord, then in that case, you take the patient up for, uh, you take the patient up for systemic therapy or radiation. Okay, so if you have a chemosensitive tumor, chemoradiosensitive tumor, for example, like small cell lung cancer or a breast cancer, there you can give radiation, and you can also start the patient on systemic therapy. Now, if the patient is radio resistant and there's no indication for surgery, then you can do surgery to separate the tumor from the spinal cord, and then you can give SBRT. So that is in radio chemo-resistant tumors, like melanoma causing spinal cord compression, right? So surgery, if the indication is there, spinal instability, otherwise you go for chemo radiation. If it is chemo radiation resistant, then you go for SBRT, with separation surgery first to separate the spinal cord mass and the mass with this from the spinal cord, then you give SBRT. Okay. So that's how you manage it. Now, if the patient's ECOG status is very poor, right? Um, if the patient has got a poor life expectancy, then you give best supportive care, or you might even consider giving single fractionation of radiation. Okay, EBRT, 8-grain single fraction. So those are approaches. So based on the performance status and the life expectancy, you might have omit and go for best supportive care. So that's how you manage a spinal cord compression. Okay.
Yes, sir.
So I hope you got that.
Yes.
Now, okay. So this is an 18-year-old male being treated for BLL on BFM 95 protocol with cough that did not subside on high-end broad-spectrum antibiotics, showing the following. Uh, uh, okay, so Dr. Praneeth, can you tell me what this is?
Sir, we can see this is a chest X-ray, mostly an AP view, showing right upper lobe collapse of bar consolidation in a known case of BLL post
Yeah, so
treatment.
also look at the history here.
Yes, sir, going through and not subsiding on broad spectrum antibiotics. And I would, sir, first suspect like any fungal infection.
Yeah, so
Was
it's not
already
that
been
clear
given.
here, but you can see that there's some sort of a cavity here with sort of a fungal bulge, looking like an aspergilloma. There's also some, infiltrate seen bilaterally in the lungs. Okay, so this is
Yes,
looking like aspergillosis with associated aspergilloma. So
yes, sir.
for aspergillosis, what is the standard treatment that is given?
Sir, according to ECLS, first we'll start with azole, sir, either voriconazole or ketoconazole. If they are not responding to it, then we can escalate to echinocandins.
Yeah.
as far as
So,
BCL is concerned.
you'll give voriconazole. You'll give a dose of oral or IV 6 mg per kg day one, then 4 mg per kg twice a day from then onwards. So 6 mg per kg BD on day one, then 4 mg per kg BD from there onwards. Okay. You'll treat the patient for 6 to 12 weeks or for more if the patient is being continued on immunosuppressive therapy. Okay. If the patient does not respond to that, you will then switch over to lipoamphotericin B or like you said, any
Echinocandin.
echinocandins. Okay. Like caspofungin. So this is very commonly seen, especially in induction cases. They keep it in the exam. Aspergillosis is a famous question.
Okay.
Okay. So, yeah, Dr. Sriram, are you there?
Yes, sir. Yes.
Yeah, can you tell me what you see here?
So this is a image showing a PET scan. Like
What sort of PET is it?
I can. It's a FAPI. Like a PSMA PET, sir.
Yeah, PSMA
Prostate,
PET.
yeah.
Okay. So
Like
the thing to
prostate
note
is
here is
being
that there is no brain uptake here. That is
PSMA,
seen in
yeah.
your FDG PET. So here you can see that there's parotid and salivary gland uptake along with kidney, liver, and urinary bladder uptake. So that show in normal tissues. That shows that it is a PSMA PET. Okay. So always look at the salivary gland and parotid, and
Yes.
there's lack of brain uptake. So that shows PSMA PET. Now, uh, so diagnostic, what radionuclide do you combine with PSMA?
Gallium.
Yeah, okay, so gallium-68. Okay, so in non-metastatic prostate cancer, in what risk groups do you use PSMA
Yes.
PET for staging as per NCC?
In non-meta, I think in intermediate and high risk.
Yeah, so unfavorable intermediate risk group, high risk and very high risk group as per NCC, and you use PSMA PET for staging. Okay, or you can use it in recurrent setting or metastatic setting. Okay, can you tell me about the role of lutetium 177 PSMA guided therapy for prostate cancer? What setting do you use it in? What is the evidence?
Sir, we usually use in the refractory setting at least post 2 lines of therapy. So it
I'm
has
looking for a particular term here.
CRPC basically.
Yeah,
Post
metastatic
2 lines
CRPC, right? Yeah.
metastatics here. That actually means the PSMA study showed a PFS benefit.
Yeah. So basically, based on the Vision trial, post taxane and post androgen receptor pathway inhibitor, you can give lutetium 177 PSMA treatment, right? And it showed a PFS benefit over, standard of care treatment. So that's where it's approved. Why do we give an amino acid infusion before giving this lutetium 177 PSMA?
Basically, it is nephrotoxic. So to wash it off, we give an amino acid,
Yeah, so
renal protectant.
Right, you're right. To prevent nephrotoxicity, right? Good. Okay, so now moving on. Okay, Dr. Ronak, what do we see here?
Sir, we see bilateral lesions. They are either some ground glass like opacities, or they could, because it's a diffuse ground glass opacities which have both solid components and
See,
cystic kind of component.
just be very simple here. This is like a spot diagnosis. Okay, this is basically cannonball metastasis to the lung.
Yes, sir.
Okay, so when you see this X-ray, you need not describe it in detail. You can just mention cannonball metastasis of the lung. So what all conditions do you see it in?
So cannonball metastasis to lung we can see in case of hepatocellular carcinoma or in case of
Not
colorectal
hepatocellular.
cancer.
What is the most common causes? So it's choriocarcinoma, renal cell carcinoma, right? You can see in colorectal carcinoma, you can see it in CA endometrium. You can also see it in melanoma. Okay. So
Yes,
those are
sir.
some of the few common causes. So this is like a spot diagnosis, just mention the causes. They're usually happy with that. Okay. Okay, now coming to the next part of our discussion, that is the instruments. So a lot of things to discuss in the instruments. So Dr. Salahuddin, hello. Is Dr. Salahuddin there? Okay, we'll go to Dr. Poonam then. Are you there?
sir.
Yeah, Dr. Salahuddin is there. Okay, so please, can you
Yes, sir.
describe what you're seeing here?
Sir, this is a bone marrow biopsy needle.
Yeah. What is the name of this particular needle?
So this one is Jamshedi's needle.
Yeah, Jamshedi needle. Can you name some other bone marrow needles?
Salah's needle
Okay,
and
good.
Clemens.
Yeah, so those two. Okay, so the parts here, you have an outer cannula, you have a stillet that you put inside, and you have a T handle to guide the needle. Okay, so
Yes.
so what all do we not the I'm not asking for the settings in which we do it, but what all can we gain from a bone marrow aspiration and biopsy?
Sir, when we do bone marrow aspiration and biopsy,
Along with that, what all can we do?
sir, I couldn't get the question. Can you
Yeah,
please
so
repeat?
so what I meant to say is that it's used to do a bone marrow aspiration biopsy. Along with that, you can also do conventional cytogenetics, flow cytometry, FISH and PCR, and MRD testing in like acute leukemias, etc. Right? So
Yes,
this
sir.
FISH and PCR can be done from peripheral blood as well. You need not always do it from bone marrow because it can be done based on anaphase itself. Anaphase, which is seen in peripheral blood. Whereas conventional cytogenetics should always be done from the marrow because it requires metaphases to analyze it, right? That is only seen in the marrow. Okay. So what are the malignancies in which bone marrow biopsy is indicated in?
Sir, bone marrow biopsies are indicated in malignancies such as low-grade lymphomas. Uh, then, along with that, we have to do it in leukemias such as AML, ALL. Also, we have to do it in myelomas for the diagnosis
Any
process.
solid tumors?
Solid tumors, sir, we have to do it in first when if we have a disease such as Ewing sarcoma because
Good.
it has predilection for a bone marrow spread. Along with that, if there is unexplained cytopenias in other advanced
Good.
malignancies also.
Okay, I think that is a satisfactory answer that you have given. So acute leukemias like ALL, AML, CML, you need to do it. MDS and myeloproliferative neoplasms in myeloma, in Ewing sarcoma and rhabdomyosarcoma, although it is currently replaced by PET-CT, but classically you used to do bone marrow as well. Okay, neuroblastoma also we do. For stem cell mobilization during transplant, earlier it was done. Currently we use peripheral blood. And any unexplained cytopenia, like you mentioned, right? In lymphoma, it is done in all lymphomas except for DLBCL and Hodgkin's disease, where you can do a PET-CT. That is enough. That is sensitive enough.
Yes.
Hodgkin's and
Yes.
DLBCL. Okay. So what side do you take it from?
Sir, there are multiple sites from which bone marrow biopsies can be
Most
done, but
commonly and rare.
most commonly it is done from posterior superior iliac spine or anterior superior iliac spine.
Yeah. So posterior superior iliac spine is the most common. You can also take it from anterior aspect of tibia, and in children you can do it from the sternum as well. Okay. So what solution is used to preserve the bone marrow biopsy specimen?
Sir, I think formalin. I'm not sure, sir.
Yeah, Boyne solution. Okay. So that consists of formalin, picric acid, and acetic acid. It's called Boyne solution. Okay. What are the scenarios where you commonly get a dry tap with a bone marrow biopsy?
Sir, we will get a dry tap in cases such as myelofibrosis.
Good.
Or we can get in
Plastic anemia.
Yeah. So I'll just quickly say it. Hairy cell leukemia, then all the myeloproliferative neoplasms like CML, myelofibrosis, essential thrombocytosis, polycythemia vera, etc. Right? And you can also get it rarely in AML, M7 and M6 subtype. Okay. So just remember those.
Yes.
Right. Now, okay. Next, we'll move on to Dr. Praneeth.
Sir,
What do we see here?
sir, we can see this is a lumbar puncture needle.
Good. Can you give a named LP needle? Quinky needle. Okay. Quinky needle. Yeah.
Quinky.
So where all is it indicated from a diagnostic perspective and from a so diagnostic where it is absolutely required upfront and therapeutic where it is also required as part of usual treatment.
Sir, in acute lymphoblastic leukemia,
Good.
to rule out the CNS involvement, we will do lumbar puncture. And in DLBCL with high risk CNS IPA, we will do
Good.
lumbar puncture. And and patients with primary CNS lymphoma.
Good.
And patients with I remember the
Yeah.
Burkitt's
So
lymphoma.
good. And one more, can you tell me?
Burkitt's.
HIV positive lymphomas, all HIV positive lymphomas. Okay.
Yes, sir.
Okay. And in solid tumors, you do it in medulloblastoma, ependymoma, all those posterior fossa tumors that have high propensity of spread. Okay. Or if there's signs and symptoms of CSF
Raised
involvement,
ICT.
right? So therapeutically, what are the sites where you need to give intrathecal treatment,
Sir,
regardless? Yeah.
one in acute lymphoblastic leukemia, we'll give IT methotrexate as a protocol in BFM 95 that we practice at our institute. In high risk CNS IPA of
Okay.
DLBCL or Burkitt's, we'll give high dose methotrexate.
Burkitt's all cases, and in other high grade
CNS
NHL?
IPA, we give IT
Yeah.
methotrexate, sir. And I think this would be.
Or if there's neoplastic involvement of the CSF, right?
Yes,
That is proven.
yes, sir.
Okay. Can you name the chemotherapy drugs that are given and the dosage?
Sir, methotrexate is given at a dose of 12 mg.
Good.
Or 12 mg per 12 mg, and cytarabine at a dose of 30 mg per meter square.
Okay, so Arasi is usually given at a dose. If it's given alone, it's given between 70 to 100 milligram. And if it's given as a part of triple IT, like we'll give, if in ALL and all, if there's upfront CNS involvement, we'll give triple IT. There it's given as a dose of 50 milligram per meter square. So 50 milligram flat. Okay, so
Flat,
single
sir.
agent 70 to 100, triple IT 50 milligram. Okay, triple IT consists of methotrexate, hydrocot, and Arasi. So yeah, what are some of the other agents?
Sir, we can give other
I'll just say it. Okay, hydrocot, thiotepa, and what are some of the MABs you can give?
MABs. No idea, sir.
Yeah, trastuzumab, rituximab can be given. Usually we cap it at 50 mg. Although it is an off-label, all these are off-label. Trastuzumab, rituximab, and also immune checkpoint inhibitors have been given. Okay. So, what are some of the side effects of giving IT?
Sir, one IT methotrexate, first, there can be multifocal leukoencephalopathy can be there. There can be an hematoma formation. There can be headache, raised ICT features can be there because of
Yeah, so CSF leak, post-traumatic headache, bleed, chemical meningitis, paraplegia, paresthesia, and even rare cases herniation, right? Which drug can you never give as intrathecal?
vincristine.
Yeah, it'll cause certain death, right? Okay. Okay, now moving on to the next instrument. Okay, Dr. Poonam, can you tell me what you can see here? Is Dr. Poonam there? Okay, so this one I'll just describe. Okay, we're going really long. Okay, so we need to finish this off quickly. So this is a PICC line. Okay, right? It is a non-tunneled, usually non-tunneled central catheter, peripherally inserted central catheter. You insert it through the basilic, brachial, or cephalic vein, and it extends up to the SVC before the right atrium. Okay, so the length so to decide the length, you measure it by taking the distance from the anterior cubital fossa to the anterior part of the axilla, then to the lateral border of the first rib, and from there to the level of the carina, and two vertebral body units, or two, you take, so level of carina, then below that you go two vertebral body units below. So that is the length of two vertebral bodies below the level of the carina. Okay, so that's how you decide the length for the PICC line. Okay, advantages are it's easy to insert. It's got lesser complications during insertion. Okay, because it's very easy to insert. Disadvantages: higher rates of infection, higher thrombosis, catheter migration, and it is less discreet. It is visible to the public. It's usually get at a size of 4 to 5 French, right? It can be single or multiple lumen. We use the Seldinger technique to insert it. And immediate complications while inserting any central line. So this applies to all the central lines: air embolus, arterial puncture, hematoma, nerve injury, pneumothorax, hemothorax, arrhythmia. So all central line insertions can have these immediate complications during insertion. Then you have your indwelling catheter complications. So while the catheter is placed inside, you can have an infection, you can have thrombosis, you can have kinking of the catheter, um, or you can have extravasation, or you can have a pulmonary embolism. So all these are complications while the catheter is indwelling, all central line catheters. And PICC line care, something you should know is that this is something they'll ask you. You should give twice weekly, ideally, saline push, right? Saline flush, 0.9%, 10 ml of NS in a syringe that is 10 ml or more in size. That is also very important. So twice weekly, normal saline, 10 ml in a syringe that is greater than 10 ml in size. And you can also add heparin with it if you're suspecting some sort of resistance, right? And dressing should be done weekly. Okay. So next we'll go to this catheter. I'll just finish off the instruments fast, okay, because we have drugs as well. So this is a
Hickman, sir.
yeah, Hickman catheter. Good. So this is a tunnel catheter. It is inserted in the jugular vein or the subclavian vein. And other examples of tunnel catheters include Broviac or Grosjean catheters. Okay. It is used for long-term use, especially like example, allogeneic BMT, we use a Hickman's catheter. Advantages, it has a lower chance of infection due to presence of tunneling, that is, it is placed subcutaneously, and it has a Dacron cuff, which prevents infections, right? It is more discreet, it has less frequent care required than a PICC line, and it can be used for long periods of time. The disadvantage is the insertion procedure is more complex compared to PICC line. Okay. So here you should know the most common complication of an indwelling catheter is infection. Okay. So you have two definitions here that they will definitely ask you. That is catheter-related bloodstream infection and central and associated bloodstream infection. So catheter-related bloodstream infection, CRBCI, is a bloodstream infection attributed to an intravascular catheter by quantitative culture of the catheter tip or by differences in growth between catheter and venipuncture blood culture specimen. All these words are very important. Okay. So usually you will have a positive differential time. Okay. So differential time between so you'll usually take a catheter blood sample and a peripheral blood sample, and the differential time to positivity between both is greater than 2 hours. That is, the catheter has faster growth by over 2 hours than the peripheral blood sample. It could be a catheter CRBCI, or on quantitative blood culture hub if there's a greater than 3 or more fold higher colony count than the peripheral blood. Okay, so there's CRBCI is quantitative. You know, you quantify bloodstream infection quantitatively based on proof of colony count as well as differential time to positivity between central blood culture and peripheral blood culture. Okay, that should be greater than 2 hours. Now, catheter CLABCI, CLABC, refers to bloodstream infection that appears in presence of a CVC or within 48 hours of removal of the central venous catheter, which cannot be attributed to an infection unrelated to the catheter. So here we're not quantifying. We are just associating that because the catheter is indwelling or it's just been removed 48 hours before, it could be due to catheter because there's no other cause. Okay, so that is CLABC. So the important difference between CRBC and CLABC is important. So once you develop a catheter-related bloodstream infection, what are the indications for catheter removal? So you remove it if there's severe sepsis, if you have a suppurative thrombophlebitis, if you have associated endocarditis or osteomyelitis, excuse me, if you have a tunnel infection, if you have infections with resistant bacteria, right, that could recur, like MDR, Klebsiella, or any other MDR organisms, or MRSA or VRSA, etc., or if you have a fungal infection, right? So in all these settings, you need to remove the catheter. So just remember those things. Also, you need to know antibiotic lock therapy, in which you, along with your IV antibiotics during a bloodstream infection, you also give direct high dose antibiotic, for example, vancomycin, into the catheter so that the biofilm, the indwelling bacteria can be wiped out. Okay, so that is called antibiotic lock therapy. Now, coming to care of a tunnel catheter, you should do it weekly, right? Once again, with 10 ml normal saline plus or minus heparin. Okay, and dressing should also be done weekly. Now, coming to chemoport, you have three name types: BARD, Cook, and Mediport. Those are the standard chemoports used. Excuse me. It is usually single lumen. So use it for long-term use. Okay, long-term intermittent use. So overall, it has less complications. It has overall, it has less complications. It has less chance for infection. It has the least chance for thrombus formation out of all the catheters. It is discreet, and the port membrane can take up to 2000 punctures. Okay. Care is given 2 to 4 weekly. So even every 2 weeks or even every month is enough. Same thing, 10 ml normal saline flush given every 2 to 4 weeks. And also you should do flush after each access as well. Okay. So I hope you got the care. Right. So, so that's regarding that. Now, there's something called the CAVA trial that you should look at, which looked at central lines in the setting of cancer patients, and they found that this chemo port had the least complication rates, least chance for infection, and least chance for thrombus. Okay, compared to PICC line and tunneled central catheter. Excuse me. So we'll move on to the next instrument. Sorry, this is the tunneled Hickman line. This is chemo port. Okay. Now, this is can someone tell me?
Huber needle, sir.
Huber needle.
Yeah, so Huber needle is used in conjunction with the chemo port. Okay. It is a non-coring needle. That is, it does not cut the silicon septum of the silicon membrane of the chemo port. So it's non-coring. It has a high flow rate. So it has a larger diameter of 90 to 22 gauge, and it has a rotating head, if you notice. So even if it gets manipulated during administration of chemotherapy, there's no injury to the septum. Okay, that is a Huber needle. What is this?
Codon set, sir.
Yeah, so codon set, it is 0.22 micron filter it's got, and it's usually given with paclitaxel because it contains cremophore EL, which can cause hypersensitivity. So it is filtered off with this codon set, right? Good. What is this?
Reservoir होता है CSF के लिए.
Yeah, this is an Omaya reservoir. Okay. So basically it is placed in the non-dominant frontal region in the frontal horn of the lateral ventricle, right? Frontal horn or lateral ventricle in the non-dominant frontal region. And it is confirmed with non-contrast CT after placement. So in this setting, they can once again ask you the IT drug doses and what all can give intrathecally. Okay. Sorry, via the Omoy reserve, what all drugs can be given. So you can give the same drugs that we discussed when we spoke about the LP needle. Okay. Indications are pediatric patients mostly. You can give IT chemo, you can take CSF samples, you can give IV antibiotics, etc. Side effects include infection, subdural hematoma, suboptimal position, including migration, neurological complications like seizures and edema, and leukoencephalopathy. Okay. Moving on. What is this?
PTBD stent.
PTBD stent.
Yeah. So this is a PTBD stent, right? And it's usually used in obstructive jaundice. So now the question is, where do you use PTBD? Where do you use ERCP stenting? So in obstructive jaundice, use PTBD if the lesion is located, before the hilar region of the bile duct, right? So usually if it's an intrahepatic lesion or if it is an intrahepatic bile duct, there with IHBRD, there you use a PTBD. If the lesion is distal to the hilum, then you can use ERCP stenting. So that's based on the anatomy, we can use either one of these two. Then, right. So you need to know the difference between a metallic stent and a plastic stent. Okay. So that is also very important. Right. So if you look at the metallic stent, it's got better patency, but yeah. So basically, if it is blocked, you can unblock it, right? Using an interventional procedure. It's got a better patency. Plastic stent has got less patency, and if it is occluded, you need to remove it. You can't remove the occlusion. Okay. So that's one more thing. Now you need to know about the complications. So it can cause bleeding, infection, bile leak, stent malfunction can occur, including blockage and migration. It can cause pancreatitis. It can cause cholangitis. It can also cause pneumothorax and perforation of the intestine. Okay. So remember all these complications that it can cause. Okay. What's this?
Pigtail.
Pigtail catheter, sir.
Yeah, so it is a intrapleural catheter, right? Intrapleural pigtail catheter. So it's used in setting of pneumothorax, malignant pleural effusion that's refractory, empymas to drain them, or for chemical pleurodesis, or for esophageal rupture with leak into pleural space. Okay, so those are all the indications. Now, pleurodesis, there are two types. They can ask you pleurodesis here. So mechanical, by inducing abrasions, or by doing a parietal pleurectomy. Then chemical includes using talc, using tetracyclines, right? So talc, tetracycline, also bleomycin 60 units can be used. So contraindications for pleurodesis is if there's a bleeding diastasis, if there's chest tube infection, or if there's a trapped lung due to involvement of the visceral pleura. Complications include infection, catheter issues like block and leak, pain, formation of lock lesions if it's kept for too long, nutrient loss, subcutaneous emphysema, and pneumothorax. Okay, so that's this also they commonly ask. They can ask this in the ward rounds as well. So be prepared for that. They can keep a patient with this. Okay. Okay, I think we had a quite extensive discussion, right? If you guys don't mind, I would like to keep the next session for tomorrow. So because I don't want to just skim through everything and so I want to have a detailed discussion. So it's already been close to 2.5 hours. So if you don't mind, I'll keep the next session for tomorrow evening. Okay.
Okay, sir.
Yeah, because I don't want you guys to just skim through everything and miss out on important points. Because my target here is that if you listen to this this discussion and go, you should be ready for the practical exams completely, right? So in order to do justice to that, I don't want to rush through the remaining things.